Okay, good morning. Good morning. Welcome today a symposium or a webinar on a Saturday morning, a very early Saturday morning. I am Shiva Maleksade. I'm one of the Anaesthetic Consultant staff anesthetists at Austin Hospital. And I realize a lot of people have given a lot of family opportunities, especially in Victoria, since this is the second week that they have been able to see their family members, especially the ones from regional areas. So I know it's a lot to give, but the best thing is that it's actually too warm to go outside anyway. We were talking a few months ago, and we thought it would be a waste to actually let all the information, all the skills that we actually gained over the past couple of months to be lost. So we thought if we actually do a webinar, that might be a good way of sharing it. Increasingly, it's looking as if we won't have another wave in Victoria. We had a 29-day in a row today, as I just announced 2 minutes ago. So epidemiologically, we've got rid of the bug. But still, there are lots of lessons to be learned to actually, if there is anything does happen, we can mitigate it, but also for future pandemics in future, for future generation. We have got a fantastic panel. They're all experts in what they did, and they worked very, very hard. So they are all happy to share their emails with you. So if you have any questions that you can actually want to forward to them, they are more than happy to help you out in there. There is a Q&A section that you can put any question that you guys want in there. The questions we will answer as many as we can, but if we can't answer them, we will put them forward to the people who actually I will be sending a SurveyMonkey in a couple of days' time as a thank you and attendance letter, which will be acting as an attendance. So please share answer it, and that actually forms part of your CPD. One of the things I saw in this pandemic was that everybody wanted to do more. I actually did not hear of any exhaustion, anybody who was unwilling to do anything. Everybody put their hands up, from young and old, and every specialty. In medicine, we usually take the credit when something does go right, and we've taken a lot of credit for this pandemic, but there have been a lot of people on the background. What I have seen from the nursing staff is unparalleled in the past. They've just, everybody put their hands up, they've chipped in, they've worked so hard. But our unsung heroes are not only nurses and doctors, but other people. I was talking to one of the cleaners a couple of weeks ago, and I said, gee, you guys are working really hard. And she said, my job is to make sure that I'll keep you guys safe. And it sounded as if she takes a lot of pride in what she does. So it's really, really important for us to actually share and make sure this opportunity is not lost. We'll start with the first session, and Tamishta will be our chair. So I will make sure she's going to be, okay, off you go, Tamishta. Thank you.
Thank you, Shiva. So my name's Tamishta, and I'm an advanced trainee from the Austin ICU.
You have to unmute.
And I'd also like to thank you for joining us all this Saturday morning. So in our first session, we have a range of really diverse topics, and they're presented by three incredibly insightful speakers. I'm incredibly honoured to be introducing them, but also interested to hear what they say. And I'll just remind you that, as Shiva said, there will be some time for questions at the end. If you would like to ask a question, please use the Q&A function at the bottom of your screen. And any questions at all about how things work on Zoom, feel free to message the panelists and I'll help you out there. So to kick things off is Dr. Clair Gordon, who's an infectious disease physician at the Austin, an NHMRC-funded senior research fellow at the Department of Microbiology and Immunology within the Doherty Institute. Her research focuses on memory T cells. Dr. Gordon had a range of roles during the pandemic, including medical lead of COVID staff exposure and medical lead of the newly created Northeastern Public Health Unit. Welcome, Claire.
Hi, thanks very much for the introduction, and thank you for the opportunity to talk today. I'll just share my screen, and if you could just let me know that it's definitely been shared. Can you all see that?
I think it's just loading, Claire.
Oh, great. I'll just double check it's up before I move on.
Looks great.
Okay, perfect. So this morning, I'll start off by introducing Austin's COVID-19 response, which really just gives you an idea of what happened in our hospital and sets a scene for the other speakers that are talking this morning. I'll then just touch on some key clinical features, risk factors for disease severity, laboratory markers of severity, and hone in on the risk of surgery in patients with COVID-19. I'll briefly comment, I should say, on treatments, because I know we have another talk later about treatments, and then finish up with vaccines, of which there's been a lot of positive news in the last few weeks, and lessons learned from this pandemic. So this is the timeline of the two COVID waves in Victoria, showing the Victorian active case rate on the left axis and shown in the blue on the graph here. And the purple is the number of COVID inpatients in our hospital, and with the numbers shown on the right axis. And you can see that the first wave was really just a ripple. It was quite small, but thankfully gave us much needed time to prepare. The screening clinic opened at the start of March, and then the first patient was admitted later in the month. We opened the COVID unit, which is a multidisciplinary collaborative team of ID physicians, general medical physicians, and respiratory physicians with ICU support, dedicated for caring for all the patients with COVID, and also patients suspected to have COVID, who we call SCOVID, before their results come back negative. One of our wards, 7 East, was the dedicated COVID ward, and I just wanted to echo Shiva's comments about the nursing staff, the cleaning staff, and just all of the staff involved in the care of these COVID patients. It was just absolutely incredible, and everyone working extremely hard to make the unit happen. So the COVID unit was a very successful model. It streamlined the testing of patients. It enabled us to keep our really stringent infection control measures in a set area, and controlling and limiting the number of staff that needed to come into the unit, and therefore limiting their exposure to COVID. So we also started, sorry, I think I've gone forward a little bit. We also started a suite of COVID apps, the first one being COVID Care, which was designed to give automated results to patients, also to monitor patients with symptoms. That evolved into the COVID positive pathways, where COVID positive patients were able to be managed through this app and also have contact with ID physicians at the hospital. And this program was quite successful. It's now been rolled out to Monash and Peninsula as well. We also developed another app called COVID Trace, which was used to manage staff contacts, and we are also rolling that out to the North East Public Health Unit. So we then have this coming to the second wave that started in July, and our admission of COVID positive patients really mirrored the number of active cases in Victoria. And as I'm sure a lot of you are aware of, we had really big problems with COVID just ripping through our nursing homes, and it would not only affect the patients, but it would take out the entire staff of the nursing home who either acquired COVID or had to be quarantined because they were close contacts. And this was really devastating. At the sort of the peak, our COVID footprint at the hospital consisted of 5 units. So 2 were with COVID positive patients, and that's, sorry, 5 wards, I should say. 2 wards were dedicated to COVID positive, 3 wards were dedicated to COVID positive patients. 2 of those were in the acute hospital, and 1 of those was at the REPAT, which was our GRE's COVID unit, which was trying to take the pressure off of all of these nursing home patients which were coming in with COVID that needed care. So in addition to those 3 COVID positive wards, we also had 2 that were SCOVID patients, so suspected COVID patients. And so you can imagine, and also there was a pod in ICU dedicated to COVID, which I know you'll hear about later. So you can see that the COVID footprint really sort of pushed business as usual to other places of the hospital. And also at sometimes during wave 2, we had to close some non-COVID units due to a positive staff member working inadvertently while they were infectious. So there was a huge amount of bed pressure. This particular day I remember well, on the 1st of August, that was when we were notified of 2 cases in Twin Parks, which is one of our local nursing homes, of which we have Austin patients in. So we very much see it as part of our responsibility. It's a 250 bed nursing home, and we were already under huge pressure. And this kind of like deflated us, because like, wow, how are we going to deal with this influx of patients? Where are we going to put them? And so it was at this time that the private hospitals started taking COVID positive patients, which was fantastic. It just really took the pressure off us, and it prevented this curve, this purple curve, from going even higher than what it is. So our peak was 80 inpatients with either suspected COVID or COVID. Stage 4 restrictions were then put in, which was another big relief. And just our last COVID patient was discharged. Sorry, I'm just having trouble seeing my. Last COVID patient was discharged. The COVID unit, which was located on 7 East, finally sort of stopped on the 11th of November, which was a big celebration for the staff there, who'd really done a fantastic role. And they said at the start they really wanted to see it out through the end, and this was despite having an outbreak related to their tea room in the middle of it, and they just were just so fantastic, just soldiering on, and they absolutely saw it to the end. So this slide is courtesy of Natasha Holmes. It's a little bit of a rough data, so I apologise for that. But to the early October, we admitted just under 2,000 COVID admissions. There was just under 500 COVID positive patients who were at the hospital. About 21% of these were classed as severe, so needing oxygen and possibly ICU support. Only 13% went to ICU, and that was because we had a lot of patients who were not suitable, were not ICU candidates. And our inpatient mortality rate was 16%, which seems very high, but again, I think that just reflects the patient mix that we were getting from the nursing homes. So I just wanted to touch on the key clinical features of COVID. It's a really interesting virus, and it has such a broad spectrum of manifestations. So 40% of people have no symptoms whatsoever, yet you get 15% who have really severe disease, dyspnea, hypoxia, 5% who are critical, and some of those die. So it's really hard to, or at least in Australia it was actually quite easy, but in a place like America, it was very hard to get that message that it's a severe illness when 40% of people don't have any symptoms. So it causes multi-system complications. We'll hear from Celia about the respiratory effects. It causes thromboembolic complications such as pulmonary emboli and stroke. It also affects the heart with arrhythmias, acute myocardial injury, and about a third of ICU patients have myopathy. It also causes hyperinflammatory responses, fevers, increased inflammatory markers, pro-inflammatory cytokines. We did see several secondary infections, particularly Staph aureus and Aspergillus, which is similar to what we would see in severe influenza. Also, there's inflammatory and autoimmune conditions associated with it, Guillain-Barré syndrome and multi-system inflammatory syndrome in children. There's also this group of patients who's been called long haulers, and they have persistent debilitating symptoms. And this is despite how, even if they had asymptomatic infection or they're in ICU, it doesn't matter. You can still develop these chronic persistent symptoms. And these symptoms can include dyspnea, muscle aches, memory loss, difficulty concentration. It does affect the patient. And the other thing that is concerning, I think just highlights how little we know about the long-term effects of this virus, is that in a study that was published in JAMA, about 60% of asymptomatic cases had myocardial inflammation on cardiac MRI. And we don't know what this means. This might just resolve in the long term, or it might predispose the individual to cardiac problems in the future. So there really is still a lot that we don't know about the long-term effects of this virus. So just moving on to the risk factors for severe disease, there's probably no real surprises here. Comorbidities including cardiovascular disease, diabetes, hypertension, chronic liver disease, cancer, chronic kidney disease, obesity and smoking. And I've just listed the laboratory markers of severity, so low platelets, low lymphocytes, elevated liver enzymes, LDH, inflammatory markers, CRP, ferritin, cytokines such as IL-6 and TNF-alpha, elevated D-dimer, elevated prothrombin and elevated troponin and CK. So I just wanted to move on to how are patients who are infected with COVID how do they do when they have surgery? And it turns out they do very badly, surprisingly badly. There was this fantastic multi-centre international study that was run by National Institutes of Health Research, Global Health Research Unit in Global Surgery, which looked at 20, this was a it was an observational study. It looked at 235 hospitals across 24 countries. 1,128 patients had perioperative PCR. So that could have been either 7 days prior to surgery or 30 days after. Of this cohort, 3/4 were emergency surgery. And SARS-CoV-2 was confirmed preoperatively in just 1/4 of those, which is my sort of infection control hat on. That sort of horrifies me that all these people were diagnosed after surgery. I think of all the staff and other patients that may have been exposed. But the real shocking thing was that the 30-day mortality was 23.8%, so extremely high. And I think even though there was ascertainment bias in the testing, so it was only patients were only tested if there was a clinical suspicion of COVID. So you may have been seeing those people who were asymptomatic or had very mild symptoms. There was no control group, and it was very much non-standardized testing and radiologic intervention. I think everyone would agree that this mortality is far too high. The other caveat is that most of the patients were from countries that were hit hard early in the pandemic, so Italy, Spain, UK and the USA, so perhaps their normal healthcare system was overwhelmed, but certainly absolutely has been taken seriously. And on the back of that, pre-surgery universal testing for COVID was brought in across Victoria. And the mechanism is probably related to severe COVID, or COVID has this sort of marked inflammatory and prothrombotic state, which is exacerbated or even sort of multiplied by surgery and immobilization. So like a lot of COVID research, there's now lots of papers looking at this. I started looking through each individual paper, and then I realized that there's recently been a nice meta-analysis which looks at this. So this meta-analysis included 21 studies with 2,756 participants, which showed a pooled prevalence of perioperative mortality of 20%. So it really was consistent with the initial multi-centre study. So complications with thromboembolic infection, pulmonary complications were the most common things that were observed. The post-operative ICU admission rate was around 15% in surgical patients, so post-operatively. And now that the question we get asked now is, so when is it safe to have surgery after you've been infected with COVID? And there's really no evidence to guide recommendations. There were a few papers that recommended 4 to 8 weeks after symptom onset. And look, I think that's fine if you've got a really mild infection or an asymptomatic infection. That's a good sort of ballpark figure, at least 4 weeks, but really as long as possible, up to sort of the 8-week mark. If surgery is needed earlier than that, obviously some surgeries needs to happen regardless of the increased mortality, but it needs to be a case-by-case discussion at this stage between the anaesthetist and ID and the patient and family. But the things that we would be guided by was symptom resolution. So, and I think absolutely people need to be free of symptoms by their surgery if at all possible. The problem is it can take some people a really long time to recover. I've just pulled out a study published in JAMA of 143 patients who were hospitalised in Italy, and only 13% were actually symptom-free after 60 days. So it's a long time. And this is probably a really severe group that were picked out in this study. But there's also emerging data of persistent respiratory impairment, which I think Celia will mention later on. And also the earlier paper of myocardial inflammation in asymptomatic people is just something to keep an eye on. The other thing that we might use is whether they've been cleared from isolation. That can be separate from the symptoms if they've had symptoms for many months. But in terms of immunocompromised people, they can shed virus, which can be culturable in the lab for weeks or months after infection. We've had a patient here who we were able to culture virus for 2 months post their initial infection. So that's a real risk group that's going to take a while to clear the virus. So just some commentary on treatments, because we're going to get a whole talk on that later by Emily. From our point of view, in wave 1, we really didn't feel like we had a lot of treatments. There was tocilizumab, which later on was found out not really to be beneficial. But when dexamethasone came on the scene, it was a real game changer for us. And this was based on the RECOVER trial. So we were seeing a lot less of that hyperinflammatory syndrome. And I think with a I don't want to sort of spoil it, but a reduction in mortality of 30% in the group that requires oxygen was really significant in real terms. Remdesivir was sort of less impressive. It shuts down via a replication, so you need to give it early when the replication's actually happening. And we've also now found that it tended to be suppressive in the immunocompromised group rather than curative. So the immunocompromised people who we're still culturing virus so long later, often they had already received remdesivir when they hit the hospital. So that's a bit of a concern for that treatment. And I just wanted to mention potent direct antiviral therapies for early therapy, because I don't think this receives a lot of attention in the media. And the benefit of this you would be able to get a quick test, quick answer, and then take the direct antivirals for a couple of days, and then everything would be okay. You wouldn't get this deterioration that happens in 2 weeks. So I think it takes COVID from being potentially a really severe disease in some people to it just being like the common cold. There certainly is a lot of research in this area, but just to highlight that as something that would be really helpful. So I just wanted to move on to vaccines, which is I'm an immunologist as well as an ID physician, so I love this kind of stuff. I'm showing the proteins that are around the SARS-CoV-2 virion. The main one that the vaccines are targeted is the spike glycoprotein, and that's because it's been shown to elicit T cell responses and B cell responses. And I've called the vaccines that are coming out now the first generation ones, because as I said, they are targeting that spike protein. But what we're finding is not everyone mounts an identical response to the spike protein. Some people develop more robust response to other proteins, such as a nuclear capsid protein, the envelope protein, or the membrane protein. So I think moving into the future, there'll be other vaccines that will also target these proteins. So I just wanted to talk about the vaccines that Australia will have available to it. So Australia has capacity to make or has signed deals for 4 COVID vaccines. We can make 2 of them in Australia, and the other 2 have to be imported in. The first one is designed and made in Australia by the University of Sydney and CSIRO. It's currently in phase 2. It's a clamped spike protein, which just means it's just a spike protein held together by a clamp, because the spike protein tends to lose its configuration, so you need something to hold it together. The second one, which we now have capacity to make through CSL, is the University of Oxford AstraZeneca vaccine, which is a chimp adenovirus, which is modified so that it can it doesn't replicate. So it's able to infect a cell, deposit the genetic material, which encodes for the spike protein, but it doesn't get any further than that. It doesn't replicate. You've probably seen in the media, there's been some mixed reports about that recently. The highest efficacy of 90% was seen in a subgroup of just under 3,000 participants, who were accidentally given half dose of the vaccine for their first dose. It's a 2-dose vaccine. And in the group that received the full dose for both vaccines had less efficacy of 60, 70%, depending on which group you look at. So I think that still needs to be sorted out. It's a real shame if this vaccine doesn't come through. It's the cheapest to make, and it doesn't have the cold supply issues that the other ones have. It's about $3 or $4 a dose, and it just needs to be refrigerated for months and months on end. So it's super easy. So I'm hoping they're going to be able to work through that. And the way they'll probably work through it is try to give this half dose to more participants. There's also the Pfizer vaccine, which is an mRNA vaccine. So the mRNA gets taken up by cells, and it tells the cell to make the spike protein. The big problem with this is it needs to be stored at -80 degrees. So that's like on dry ice or in specialized freezers. So that's a problem. It can be at room temperature for short periods of time, but the distribution is going to be quite difficult with this vaccine. The fourth one Australia has signed on to is Novavax. I haven't seen a lot of the results yet on this. It's just in phase 3 trials, similar to the CSIRO one. It's a spike protein and an adjuvant. And just to mention that another vaccine you might have heard in the media, Moderna, which is the NIH American vaccine, that's shown really great efficacy, as has the Pfizer one. Doesn't quite have the storage problems of Pfizer, but it still does require a bit of cold storage. It can be in the fridge for 28 days, which is longer than the Pfizer one. So just about implementation, vaccine hesitancy will be a problem which needs to be addressed. There's a recent study from ANU that shows that 1/3 of Australians have hesitancy about the COVID vaccine. So this will need to get worked out as we roll it out. The good thing about COVID is we don't need to get the high levels of vaccination to achieve herd immunity like we would with the measles vaccine, which is much more contagious. So with measles, we need more than 90-95% vaccine coverage to get herd immunity. With a COVID vaccine, it's probably more like 70 or 80%. So that's sort of much more achievable. And the other unknown in all this is we don't know how long following natural infection and vaccine the immune response will last for. And that's a big question mark over this. Maybe we're going to need booster vaccines every year. How is that going to look? Are the vaccines going to be as effective the second time round? This is a real unknown at the moment. So I'm just going to finish up by just some lessons learned. Like, I think the pandemics are unpredictable, anxiety provoking, with a lot of high stakes for everyone. And I think it was really important, and which we saw at the Austin, was this maintenance of respect and kindness for everyone, no matter what their role, situation or opinion is really important. It's certain that no one has all the answers, and if you think you have the answer, it's probably going to change in a few weeks' time. So just understanding that and having empathy for others was really important. Teamwork, working in a multidisciplinary team worked really well and was vital for our response at the health service. And some fantastic linkages were made between departments, which I think will endure into the future. And just thinking more broadly, the COVID response has emphasised the importance of both public health and science, and it's really crucial that you have capacity and capability already in these areas, ready to be ramped up so that you can start working to control a new pandemic pathogen as it arrives. So we really need to have solid institutions and health services capacity to be in the best place to deal with these pandemics. So I'll just thank you there, but absolutely thank you to the COVID ID team, particularly Jason Tribbiano and Jason Krong, who led us all. Also to Natasha, Kira, Liv and Morgan, who are part of the COVID team with me, and the other members of the ID department, Lindsay, Pat, Michael and Paul Johnson. Thank you very much for your time today.
Thank you so much, Claire. That was really insightful. Thanks for your time. So we'll move right along, and I'd like to introduce next Dr. Louise Ellard, who's Deputy Director and Staff Anaesthetist at the Austin Hospital, as well as Honorary Clinical Lecturer in Anaesthesia at the University of Melbourne Centre for Integrated Critical Care. Dr. Ellard attended the University of Medicine Medical School and completed her anaesthesia training at Austin Health in Canberra Hospital, and she was also awarded the Cecil Gray Prize for the FANSCA Part 2 in anaesthesia exam in 2009. Her clinical interests include cardiac surgery, liver transplantation, and major hepatobiliary surgery. And she maintains a strong interest in difficult airway management, authoring several book chapters and review articles on the topic. She's also, in her spare time, recently completed a master's in clinical leadership. Dr. Ellard led the Austin Health Department of Anaesthesia Response and COVID Working Party, and I'll invite her to share her experience with us today.
Thanks very much, Tamishta. Could you just confirm that my slides are projected?
Yeah, that looks great. Thanks.
Thanks very much. So good morning, everyone. I'm delighted to talk to you today about the Austin Health Department of Anaesthesia response to the COVID pandemic and to share our journey with you all. By way of an overview, our response could be considered under three main headings. Initially, the establishment of a crisis leadership structure and alterations to staffing, theatre management of both COVID and non-COVID cases, alignment and coordination with other departments and the direction of the organisation. And I'll finish up this morning with some of the lessons that we've learned that we'll take with us along with the other happy memories of 2020. The first step in establishing our crisis leadership structure was to determine our department's vision. And that was to minimise the risk to all staff, avoid even a single case of coronavirus transmission to healthcare workers associated with airway management, and to use the skills and the expertise of anaesthetists to assist the organisation and to optimise patient care. We established a group of anaesthetists to form the COVID Working Party to operationalise our department's response. This working party comprised 4 consultant anaesthetists who each brought different strengths and skills. And everything that I present today really is on behalf of my 3 colleagues, Doctors John Graham, Daniel Banyas and Lachlan Miles. Our group of 4 was assisted by leaders within our department in the areas of education, simulation, PPE training, communication via different platforms and staff welfare, and some of those leaders will be presenting later this morning. It's hard to remember what March 2020 felt like, but it was a time of great uncertainty, accompanied by a feeling of immense time pressure. So our strategy was to get a group of people trained initially and then sequentially expand on this using a just-in-time approach, ensuring everyone was trained before they were potentially exposed. So to allow us to prioritise and tailor our training, we split our anaesthesia staff into 3 discrete groups, and staff were allowed to nominate which group they would belong to. We called these groups Alpha, Bravo and Charlie, and we made a deliberate early decision to exclude our anaesthesia trainees from the highest risk interventions wherever possible. So trainees were included with the Bravo group. And I will elaborate a little bit more about the intubation team later on in the presentation. The second broad category of our response was the change in operational management of theatre cases, necessitating changes for all patients, not just those who had been tested positive to COVID. Alterations to our theatre infrastructure included designating 2 dedicated COVID theatres with reconfigured air handling to minimise the risk of contamination. And specifically, that meant that these 2 theatres were made negative pressure relative to the anaesthesia and setup rooms. We blocked direct entry into those operating theatres from common areas using temporary hoarding in order to minimise the risk of contamination outside of the operating room, but still allowing that theatre to function with high air exchanges and laminar flow. A really big day-to-day change for those in theatre were the changes to our PPE, and our department really led the communication and education around this within the theatre complex. And that included the need to constantly navigate around the frequent changes according to DHHS guidelines and the advice of our internal infection control. We completed a fit testing program for anaesthesia nursing and medical staff who would be potentially required to manage SCOVID and COVID patients, with great thanks to Lawrence Weinberg and Caitlin Lowe for kicking that off within our department. And although the overall Victorian response to fit testing is behind that, certainly of our South Australian colleagues, we were really keen to get ahead with this. So I'm very grateful that some of my colleagues pushed very, very hard for this important testing to happen. And it meant that we were able to test just about all of our frontline anaesthesia staff early on in the second wave. But pleasingly, a statewide comprehensive respiratory protection program is now being rolled out. In response to the challenge of constantly updating advice, we established and updated posters and cheat sheets that were distributed throughout the theatre complex, which in and of itself was a monumental task given the frequently changing advice. And I think Norma in our print room probably worked harder than anyone throughout the pandemic. And I'll show you some examples of these posters next. We also instituted a COVID-specific timeout at the start of each theatre list before the patient was brought into the room to discuss the PPE requirements for each staff member. And we established a team of COVID monitors who were on the floor in theatre each day to answer questions and to aim to be a single source of truth for the various requirements. Just to preface the next few slides, where I'm going to show you a number of our posters, because these have changed so many times throughout the pandemic. These are just examples, may not be the most recent ones with our current processes. So please just keep that in mind if you're planning on using these specific templates. So starting with these simple examples, we had donning and doffing posters to remind staff of the involved steps. These are the versions that we used for our PAPA program, which was restricted to the alpha group anaesthetists and anaesthesia nurses, whom we trained and whom form part of the COVID intubation team that I'll discuss in more detail in just a second. To assist with making all of the requirements clear for all theatre staff, we designated 3 different patient pathways. These 3 pathways in order of escalating requirements were a negative pathway. That was patients who had a negative COVID test result and a negative screening checklist. In the middle, the no result pathway, and this was for asymptomatic patients who were not suspected of having COVID, but for whom we did not have a test result. And that was usually because of clinical urgency to theatre and no time to wait for a test. And then we had a suspected confirmed pathway for patients who were being managed in the hospital as SCOVID or COVID. We also had a series of posters that were on each entry door to every theatre, according to the pathway and the case underway. So effectively, each pathway was also split into 2 groups according to whether aerosol generation was required at the start and the end of the case only, related to airway management, or if there was aerosol generation throughout the case in something like an ENT procedure or a maxillofacial procedure. For those of you outside of Victoria, for a period of time during the second wave, we had a DHHS-driven requirement for an aerosol settling time to be observed following an aerosol generating procedure, during which time staff in the room were limited to those absolutely required and needed to wear aerosol level PPE, that is N95s or equivalent. So in order to operationalise this, rather than applying a standardised 15 or 30-minute lockout, given that we had in-depth knowledge of the air handling for all of our theatres from earlier in the pandemic, we were able to apply a specific lockout time to each location to avoid unnecessary inefficiencies in locations where the air handling was superior. And we calculated that lockout time based on the international standard of 5 air exchanges. That distinction wouldn't have been possible without very clear signage, so that all staff working in that location on a given day were clearly aware of the times. You might be thinking, well, why bother? Why not just have a standardised time? The reason that we did operationalise this is that some of our theatres had an aerosol decrement time of only 5 minutes because of very superior air handling, and others had 30 minutes. And given that the lockout period was required at the start and the end of the case, you can do the maths for yourself in terms of the time saved, as well as the benefits really for staff satisfaction and for patient safety. Even though I'm sure the approach to airway management will be familiar to most of us 9 months into this journey, I thought I'd just very briefly share our approach to the intubation of COVID and SCOVID patients. So we pre-oxygenate via a closed circuit with a viral HME filter using the anaesthesia machine. And we placed an anaesthesia machine in each of our satellite intubation locations in the emergency department and intensive care. Pre-oxygenation was followed by rapid sequence induction, ensuring adequate paralysis using rocuronium in most instances. And one silver lining on a Friday in mid-March this year was the rapid approval of 4 new glide scopes, which more than doubled our existing fleet of video laryngoscopes. This became our preferred device for intubation throughout the pandemic, given the separate screen, the disposable blades, and the ability to use either a MAC or a D blade. Following intubation, bearing in mind that PPE makes auscultation difficult, if not impossible, confirmation of placement was with end-tidal carbon dioxide and observation of equal chest movement. We used 2 pairs of gloves for intubation of these high-risk patients, with the outer pair being removed immediately following intubation, straight into a plastic bag on the patient's chest, alongside the other airway devices. If a circuit disconnect was required, we did this with the filter in situ and clamping of the endotracheal tube. We had pre-made intubation packs for both males and females that were taken to each intubation to ensure everything that was required both for your initial intubation plan and for rescue plans were to hand, whilst avoiding contamination of airway trolleys and other non-essential equipment. Although our preferred approach, if a surgical airway was required, was going to be to use a scalpel bougie technique, in the belief that this was less likely to generate aerosols than a cannula technique and using high flow oxygen delivery, recent emerging evidence suggests that that's not necessarily the case. However, our surgical airway kits contain all the equipment for a cannula cricothyroidotomy, including oxygenation via a cannula and the scalpel bougie techniques according to the Herd Royal Perth algorithm. So clinicians were free to choose whichever technique they preferred if they found themselves in a situation which to date has not been required. Early on, we also made some recommendations about minimising aerosols for all patients, regardless of their COVID status. And that included recommendations such as minimising staff in theatre during intubation and extubation, and of course, ensuring appropriate PPE for all staff involved. Considering if local, regional, or neuraxial anaesthesia was suitable in place of general anaesthesia. Choosing the airway that was going to create the best seal, the lowest risk being with a cuffed endotracheal tube, followed by a second generation well-seated laryngeal mask, with the highest risk with bag mask ventilation. Adequate pre-oxygenation with a tight mask seal, a 2-hand vice grip, avoiding high fresh gas flows, and considering avoiding bag mask ventilation prior to securing the airway if safe to do so. Ensuring paralysis prior to intubation, careful disposal of airway equipment following airway instrumentation. And again, although recently some evidence has emerged about the use of high flow nasal cannula, and perhaps the problems surrounding aerosol generation are less significant than initially thought, we did discourage its use in theatres and endoscopy, mainly because instances of use were often just because it was there rather than a strong clinical indication or absolute requirement. We also discouraged open suction of the airway, unnecessary circuit disconnections like during transfer of the patient from operating table to the trolley, use of nebulizers, use of non-invasive ventilation, and use of local anaesthetic spray to the oropharynx, for example, prior to endoscopy. And we also intubated all patients for bronchoscopy rather than our usual practice of topicalisation and sedation during the height of the pandemic. And finally, we made some changes to the location of airway management, including things like removing laryngeal masks in theatre rather than taking that patient out to recovery. So the final thing I wanted to talk about was the role of the anaesthesia department in the broader organisational response. In consultation with our ED and ICU colleagues, in the knowledge that overall risk is reduced by having the most experienced person available intubate the airway, we established an intubation team comprising 15 consultant anaesthetists and 15 anaesthesia nurses who were rostered initially in teams of 4 and later on in teams of 3 to 12-hour night and day shifts. And for many of us, this meant a return to sleeping in the hospital for the first time in many years. This team was highly trained. They were PAPA trained. We used extensive simulation rehearsal such that we were able to don the PAPA, get to the location of the patient within a matter of minutes, and then get that patient to one of the primary dedicated intubation locations. That primary location was in a negative pressure room in intensive care, and we set up a secondary room in the emergency department. Wherever possible, we adopted a scoop and run approach to one of those 2 dedicated locations. The intubation team was activated by ICU for any SCOVID or COVID intubations, or for any patient in whom a history could not be taken. And for a period of time there, that included the vast majority of patients who were arriving into the emergency department needing rapid airway management. This team also attended all code blues for that period of time for SCOVID and COVID patients. Although thankfully this team was not required for a large number of intubations, over the 5-month period that it was in existence, we intubated 31 patients, of whom only 5 turned out to have COVID. The vast majority of these intubations occurred in that dedicated negative pressure room in ICU. And we encountered 4 difficult airways when that patient was being intubated by a consultant anaesthetist. The simulation program, Stephanie Chen will talk about later on this morning. It was absolutely vital for our COVID response. And I won't go into details, but certainly one of my personal lasting memories of 2020 will be the early days of simulation when visitors were still allowed in hospitals. And I recall racing to get dressed in a PAPA, moving rapidly to the ward where our mannequin patient was waiting for us, moving the mannequin to the dedicated intubation location, being watched by a variety of bewildered patients and visitors. And I thought I'd finish with just a few things that we've learned throughout this journey that we will definitely take with us, hopefully for non-pandemic activities in the future. But in case we do have to encounter ongoing or similar events, we'll definitely be able to apply these learnings. Firstly, the capacity that our colleagues have for change is absolutely enormous. Perhaps the fact that these were new processes rather than attempts to change ingrained processes meant that largely we had tremendous support and buy-in for any change. Black and white instructions that are followed every time are best. Shades of grey simply don't work. And that was the reason behind the creation of our 3 distinct pathways, which removed the need for interpretation and a case-by-case analysis of risk. You simply needed to decide which pathway your patient entered based on black and white criteria and proceeded down that pathway. Logical inconsistency also doesn't work when you're dealing with intelligent people, which unfortunately for us applies to pretty much everyone in our workplaces. So in designing our protocols and processes, which did require quite a bit of interpretation in order to operationalise the guidance, we always applied the logical consistency argument. So to give you an example of that, during the period of time when a lockout was required following an aerosol generating procedure, the DHHS requirement was only following intubation. And that was the approach that some smaller centres in Victoria took. However, our approach was either you believe in aerosols being problematic or you don't, and therefore the aerosols created at extubation were just as problematic as those generated at intubation. And in fact, subsequently in a number of studies, it's looking likely that aerosols at extubation are probably more significant anyway. So as a result, we applied lockouts to both intubation and extubation. It'd be fair to say that at the start of this journey, the amount that we needed to accomplish in a very short period of time was overwhelming. 3 things that helped with that was dividing the task into manageable portions, like the splitting of our almost 150 staff members into 3 groups to allow gradual training of the whole group, with having a dedicated group of staff ready to go in the initial days. Many hands really did make light work. And the working party concept was fantastic. This brought together 4 individuals who each brought quite different skill sets, but who were completely immersed in this process day in, day out. And thirdly, this journey really reinforced to us the substantial contribution that, that our anaesthesia nurses bring. We found that if we set the direction for our nursing colleagues, not only would they implement, but they really improved it. And our lesson for the future is that if you want something to happen, engage and empower the nursing staff, and there'll be an absolute explosion of productivity. We were reminded of the valuable contribution that simulation can bring to designing processes, as well as rapidly educating others to use these processes. And finally, our department's ability to work collaboratively and respectfully with other departments in the hospital, especially our critical care colleagues, was definitely enhanced by pre-existing relationships. And we were fortunate that some members of our working party were already running cross-specialty simulations with our colleagues in emergency and in intensive care, and that seemed to help tremendously. Thanks very much for the opportunity to present today. Happy to take any questions at the end of this first session. I've popped my email address there, and feel free to email with requests for additional information or questions that we don't get to at the end of this session. Thanks very much.
Thank you so much, Dr. Ellard. And I'll just remind everyone that you can submit your questions either through the chat function or the Q&A function, and we'll get to them right after this next talk. So next up, we have Dr. Celia Lanteri, who's a respiratory and sleep physician at Austin Health and medical director of the Austin Respiratory Laboratory. She gained her medical degree at Flinders University in South Australia, a PhD in paediatric respiratory physiology from the University of Western Australia, and a Masters of Applied Science from Swinburne University. So thank you so much for being with us today, Celia, and I'll let you take it away.
Thank you very much, and thanks for the invitation to speak today and the fantastic talks we've heard so far. It's a really great opportunity to share the respiratory department's experience through the pandemic. And as mentioned previously, we've certainly developed a great and a detailed relationship with a number of our departments that have worked really well. I'm sure will be enduring. So just to try to give you a bit of a respiratory unit flavour from what we saw, sort of looking more at the ward side of things rather than the theatre and intensive care side of things, and to try to complement the other talks given previously and also to come. So like everyone else, when COVID was unfolding back in March and February, March, we were hearing about things and thinking about how this respiratory illness or virus was going to affect our practice and our patients and what we might see. And there's a number of respiratory issues that have been identified or were identified gradually during the pandemic, including, clearly the sort of dominant idea of a viral pneumonia, potentially with secondary infections, the inflammatory response, and then the subgroup that developed a nasty ARDS type illness requiring significant support. And also the observation that venous thromboembolic disease was a significant or could be a significant factor with microscopic and macrovascular clotting noted in cases with severe disease. Things like organising pneumonia, where there's a sort of a consolidative response to the lungs and inflammatory reaction to the illness, became apparent that it could be an issue in trying to tease apart that diagnosis from the infection itself. And doing all of this while we're also trying to think through how we're going to look after our usual respiratory patients with respiratory symptoms and already initial compromise at baseline, including many conditions and particularly those already starting with chronic respiratory failure. And so I just wanted to touch on a bit about our department and its case mix and how that dovetailed into the COVID pandemic situation. We've already heard a lovely summary from Claire about the COVID unit itself, but where we fitted into that structure. And just wanted to raise a few of the tricky issues from a ward perspective that we've encountered, which clearly overlap with many of the other sites in the hospital system as well. And finally, we've got a COVID clinic established as well, and I've got some information regarding early follow-up of our COVID patients to speak to, which is quite interesting. So our Austin Respiratory and Sleep Department is the sort of home base for the Victorian Respiratory Support Service, which provides non-invasive and indeed occasionally invasive ventilation outside of an ICU pattern context, and also tries to support those patients in the community. So our respiratory ward has a high level of skill and experience with ventilation in general in this context. It includes a ventilation weaning unit where we are able to take some patients which are difficult to wean from ICU settings if they've got single organ failure, and bring them to our specialised ward area to try to improve their chance for weaning or transition them to a form of ventilation that can be supported in the community. And so we also have a high level of ward nursing and allied health skill set a tracheostomy team in the hospital that's excellent for managing trachecare throughout the hospital, but also supporting our patients in the community. And our patient population includes a number of people with chronic ventilatory failure who are on ventilation in the community. And all of those issues mean, one, hopefully we have some skills that can be used during COVID, but also we're quite fearful of how the illness might affect our vulnerable patient group. We've got, on top of this, we've added to our usual multiple sort of general and subspecialty clinics, the new COVID follow-up clinic, sort of coordinated by Dr. Harry Wimneswaran, and I'll look forward to presenting a bit of information about that. And the usual business of respiratory units includes bronchoscopy, and we have a large and active lung function laboratory. And as you imagine, every aspect of our service was affected by COVID. So as Claire's very nicely outlined, the COVID unit was multidisciplinary in many ways, with the infectious diseases lead, importantly coordinating the patient flow and the testing for COVID and clearance from COVID precautions. But there was a COVID med bed card, so general medicine taking a very large proportion of our COVID and SCOVID inpatients for ward management, but also a COVID respiratory unit to try to make sure that the patients who would normally be admitted under the respiratory unit or had primarily respiratory issues had access to our skill set, and some of those patients were managed in single rooms on the respiratory specialist ward as opposed to in the dedicated COVID and SCOVID wards. And at the height of the second wave, as mentioned, as it was crashing down on our heads, and the COVID geriatrics unit was added into the mix, which was a really incredibly valuable addition to take the large quantities of aged care patients with a very specialised and appropriate skill set for managing them in an additional capacity. And so we had, as Claire's mentioned, a number of wards for either dedicated COVID or SCOVID, with some flexibility to increase and decrease that depending on demand at that stage of the pandemic. The unit through ID primarily was running the screening clinic, and as mentioned briefly before, and perhaps a really good opportunity to explore further in the future, sort of that process of using IT capability to monitor outpatient symptom reporting, and indeed potentially objective measures, is to try to identify those in the community with COVID who may have been identified as having deteriorating symptoms and needing clinical review and potential admission. And finally, that COVID clinic set up rapidly, which I think will be a very valuable resource to follow up all the good work that's done during the inpatient stay. So the issues, the thorny issues that sprung to mind when thinking about what lessons to learn or what were the challenges. No surprises really that oxygen delivery, it's always been a difficult area to encourage people to use in a very evidence-based way around the hospital. But just to put some perspective about COVID and things like oxygen delivery, that about 80% of the COVID patients in our hospital did not require oxygen. So the vast majority of people who came in didn't have catastrophic respiratory failure, but still required care and observation. And those that did require oxygen, most of them were adequately managed on low flow oxygen, nasal prongs or Hudson masks. And the small subgroup that required more intense respiratory support, such as high flow oxygen or positive pressure ventilation or CPAP or consideration of intubation, was, as you'd expect, a small proportion of patients, but required took a great deal of thought and energy and effort and discussion to manage that. And in particular, things like the definition of high flow, it's an arbitrary idea and abstract with no defined concept of what that means. And the actual definition of what is it, 10 litres a minute, 15 litres a minute, or 35 litres a minute to overcome patients' peak inspiratory flow demand in respiratory distress. In reality, the important sort of approaches were around minimising the flow required to maintain a target saturation and really trying to encourage people to use that idea of a target and defined saturation, usually 92%, but 88 to 92 in those with pre-existing respiratory conditions or at risk of hypercapnic respiratory failure. And there was some confusion about that, or debate potentially. A lot of the COVID literature talks about 94% being sort of a marker of severe disease if it fell below that. Although, as we know from our oxygen association curve, the difference in PaO2 between 94 and 92%, and indeed the reading errors of oxygen saturation meters are a couple of percent the best of times. So trying to keep, to balance the caution that people had for using potentially aerosol generating procedures, high flow oxygen or positive pressure in those patients that needed, and not over treating patients who didn't require too much additional support. And of course, as I mentioned, non-invasive ventilation is really a very large part of our core business in our respiratory department. So how we were going to deliver our standard of care to our existing non-COVID patients or anybody who came into the hospital requiring our service at that time took a great deal of work was done in preparation during the pandemic to think through these issues. I know that that Jane's going to speak later in some detail about various equipment approaches, but just to touch on how our unit looked at the equipment that we had available and indeed collaborated with the ICU teams about what might be available in terms of both expertise and equipment. We explored bringing in some dual limb circuits to add to our usual single limb circuit ventilators that we use on our ward, and indeed put the configuration with filter setups and a whole lot of information and work about how to do that safely in a stepwise educational process through our excellent BRSS physio lead team. In the end, we used this sort of filtered circuits predominantly in just a couple of COVID BRSS patients, and very mercifully, we did not have a problem so far, touch wood, with COVID positive cases in our established BRSS patients on ventilation. So we had a little bit of experience about putting these into action, but not as much as we feared, which is a good outcome. We also use these filter circuits in some diagnostic work or titration studies in our sleep laboratory that assists with ventilation setup and fine tuning in our patient cohort. And it's probably there in those patients that some of the issues that potentially might be relevant for the change in circuitry were flagged, including or leading to some good bench work with lung simulators, looking at the filter effects on flow and pressure, and indeed, probably most importantly, triggering and therefore ventilation synchrony with our spontaneously breathing patients. So it's been some excellent work done in the unit to try to prepare ourselves if we needed to roll this out on a larger scale. And all of that sort of effort and energy put into ensuring that this equipment was appropriate and adjusted to ensure safety. The other aspects of patient safety on the ward setting, when we're talking about using whether it's high flow, respiratory patient or non-invasive ventilation, is those goals to use it in the safest possible way. And while ideally a single negative pressure room and with this sort of closed circuit configuration and filters is ideal for staff protection and minimising staff contact, it became really apparent that these patients who by definition have respiratory failure and are very unwell, that these things also lead to conflicting potential decrease in our ability to observe them closely, and our skilled nursing staff who normally would be able to continually visualise these patients now had them behind a closed door, and how we tried to work to avoid a reduced level of care by sort of confining those patients in the ideal situation and still providing them with the important support and observation and assessment that's required for these unwell patients. And that's an ongoing discussion, I think, about the best way to be able to do that, and to not automatically, particularly in low risk situations, assume that everything must be done only in one way, and in the process lose the sight of safety of your actual patient care in other ways. So the challenges that we faced are similar to those identified in many, in many other aspects of the hospital. We are clearly involved in a number of potential aerosol generating procedures for our respiratory patients, and trying to balance that standard of care and staff safety and patient safety was and remains a challenging issue that I think there's good work to continue to be done there. There was also learning about this new disease and how it presents. So again, I'm sure others will touch on this, but there were patients with very high respiratory rates and work of breathing, but who were not hypoxemic. So the idea that patients who would normally be at MET-call criteria on the hospital wards, but not necessarily hypoxic at that stage, along with those who seemed quite comfortable but had some quite surprisingly low oxygen saturations at times. And the parameters around MET-call criteria and care on the wards needed to be either reviewed, or the location where these people were monitored and admitted needed to be reconsidered to be able to keep things safe. So the use of the ICU dedicated pod, or the potential use of it for monitoring what normally would be respiratory high dependency patients, but who we have a shared space, a shared part of our ward, and therefore not appropriate for COVID or SCOVID patients at that stage. I think there really has to be close collaboration between the best place to observe a particular patient with a particular issue when they remain under COVID precautions. And there was much debate about when was, would the respiratory ward itself become a COVID unit, or although that would potentially compromise our care to our non-COVID respiratory patients. And we moved our ventilation unit down to another area of the hospital as part of the spinal unit to try to separate out our weaning patients from the potential of a single room COVID and SCOVID patients being managed on our ward. So I think there clearly has been fantastic innovation and rapid development of monitoring tools and reporting tools, as Claire has mentioned, and that should be and can be expanded not only for monitoring people in the community, which is important for our telehealth sort of assessment of patients. It's very difficult to get people to come in and be examined these days, and most of our patients did not want to come to hospital during this time for review. So having some form of objective way of assessing that, and there's still a lot of work to be done there. But as I mentioned, I think even monitoring from the nurses station into a single closed, a single room, being able to better observe or monitor patient care from a distance is in another area for significant development. And it's really made us also reflect on our previous standard practice, our tracheostomy team, our respiratory function laboratory, the way we do bronchoscopies, just reflecting on what our standard practice has been, and has that been as good as it should be even in non-pandemic times? What are our ongoing plans for what we do in the future? So sort of my summary thoughts overall about how we prepared, or what we thought were going to be the issues. We know there's enormous coverage, media interest, and a lot of work done about PPE, about increasing ICU beds, about sourcing ventilators. But it turns out also that some incredibly valuable resources that were needed were negative pressure rooms, single rooms in a hospital environment, just the sheer number of ward beds, because we know it's only a small, 10% of COVID patients might go to ICU. So it means there's 9 or 10 times as many ward beds potentially required. And of course, staffing, keeping staff safe, but also whether the staff flow is divided into teams, how can they best manage and support their work. And I think there's room in technology, as I mentioned, to improve, many aspects of our core business. and the rolling out of communication technologies such as Teams and use of online communication has been amazing. Hopefully that can continue to expand in other environments. So Claire's already given you a snapshot. I just thought I'd remind people of what it looked like on the wards in terms of admission, and these are COVID positive admissions. First wave, we had about 38, I believe, patients overall who were confirmed positive. And of those, 4 were intubated and only about 8 were requiring oxygen. And it was before we knew we had useful dexamethasone treatments, and no patients received that for the indication of COVID in that first wave. There was 1 death, which was a gentleman palliated in ICU with multiple comorbidities, who was intubated relatively early on in the pandemic. And I think over time we've adjusted our thresholds for various treatment options that I'll let the ICU team expand on later on. In the second wave, we had a sort of a 4-fold increase in positive cases, about 160, but still only 6 intubated, 32 requiring some level of oxygen support, and a similar number needing receiving dexamethasone. And again, there'll be further talks on treatment options in the future. And in that second wave, we had 31 deaths. And I understand that none of them happened in ICU. So the patients who were selected and identified and supported in that high level environment were well supported and effectively supported in that context. And unfortunately, the vast majority of deaths occurred in the aged care population. And it highlights again the need for that geriatric expertise and resources to help support patients with those needs, as well as supporting those who are most acutely unwell and those patients who might not be considered for that high level ICU type support. So overall, 198, about 200 patients with a mortality that seems reasonably high, but and that fairly sounds like worldwide standard type ICU admission rate of around 13%. So the respiratory follow-up clinic, we've had that underway. Harry's worked really hard at trying to follow up on some of the patients that we saw over time to ensure that we weren't missing significant morbidity into the future. And the structure is we do a 4-week telehealth review, followed by an 8 and 6-month face-to-face review with lung function measurements and further investigations, usually involving some chest imaging. And in the first wave, we offered this to our 31 out of the admitted patients. And we also offered it to 21 outpatients who'd been identified as having persistent significant respiratory symptoms, even though they didn't require admission. And in the second wave, which, as we've mentioned, was much bigger, we certainly couldn't offer it to all admitted patients without completely dominating or overwhelming our capacity. So we've offered a follow-up to the 34 admitted patients who required some form of respiratory support or ICU, so oxygen or ICU. And we've also received a handful of outpatient referrals from GPs, and including some healthcare workers. And Harry's very kindly given me some of his early information, just a quick snapshot, and of the symptoms that through a number of questionnaires have been identified in the patients as he's been following things up. And we recognise that, during the acute phase of the illness, the blue bars tell us that those viral symptoms of dyspnea, cough and fever were predominant. But at follow-up, both at 4 and at 8 weeks, things like dyspnea and fatigue in particular were very prevalent, sort of between 30 and 60% of the patients at follow-up appointments, still having significant issues. And there was a number of pain complaints, sort of myalgias, chest discomfort or tightness, sore throats, that persisted in a proportion of patients and has also been observed. Harry also reported that the actual sort of anxiety and distress of individuals attending clinic, probably even especially in the first wave, which is where we've got the majority of our information today, that these people were quite traumatised by their experience. And I guess as we all were, if we remember back at preparing for the first wave and responding to it, it was pretty bewildering for the people who were actually in the beds, being looked after by people in PPE, the media, that all the whole world could talk about was this virus and its potential destructive nature, and they were one of the few people who actually had it. So they found the process and the experience quite frightening overall, and there was a lot of debriefing, I understand. The impacts on mood and sleep has been discussed, has been identified as a major issue, and was borne out also in our observations in follow-up clinic, as well as concentration and memory difficulties that persist in some people. So we've used the clinic as a way also of referring people onto relevant services for their symptom group, and also dovetailing into pulmonary rehab to get these people with significant exertional dyspnea dealt with a little better. But also sleep services involving our rheumatology services and some chronic disease follow-up as well. And all of these sort of patterns have been borne out in other places around the world where fatigue and dyspnea after in the recovery phase, many months out, have been identified as a recurring issue, both in the admitted population, but also in a more mild outpatient population with COVID. And similarly, quality of life reports and mood reports and sleep quality have been identified to be reduced in a significant number of people who've had COVID. The lung function data that we've managed to obtain so far, a quick look at that. There's still work to be done to pull apart what it might mean, but we can see in the first milder and smaller wave, we've got some lung function measurements at 8 weeks in 24 patients where we've had a few with reduced gas transfer and maybe some airflow obstruction, but even the outpatient population had a similar number of abnormal results. But in the second wave, where we clearly saw more severe disease and a higher number of patients, we have a much higher proportion of patients with abnormal lung function results that we were detecting at our 8-week follow-up. And so 57% of people that we've tested in the first lot that have come through have had at least one abnormal lung function parameter, often gas transfer, and interestingly, lung volumes as well, suggesting that there's some persistent abnormality, at least at this stage, in some people, which we'll continue to explore. And we've referred on to our specialist ILD clinic a number of patients to continue to review their radiology and monitor for potential development of interstitial lung disease, post-infective fibrotic change. And we had a small number that have been identified during the course of our of their care that have had maybe some thromboembolic disease, primarily in the recovery phase, with some interesting work to expand on markers for that. And so just to sort of round things off, I'll give you some pictures about a patient who was quite unwell with COVID, never intubated, but supported in ICU and on the ward for a long time, who presented back in July when it was all happening with pretty classical COVID pneumonia, peripheral ground glass changes, basal predominant changes, some crazy paving in the right lower lobe. He was supported and did both. He did quite well with self-proning. He would put himself onto his front to improve his oxygenation at times, received dexamethasone, and very slowly made some recovery. He got home, but a couple of weeks later, he had a deterioration in his symptoms and increasing hypoxemia and was readmitted. And follow-up scan at that stage has demonstrated that while some of the ground glass has improved, he's developed some dense consolidation, peripheral consolidation in those middle images. And this was thought to reflect an organising pneumonia type pattern leading to his subsequent deterioration. He was given some further steroid courses to target that particular condition, and again, slowly improved. And now in clinic, where we have the opportunity to follow him up, and his most recent imaging has shown a significant improvement in his consolidation, but he now has a residual peripheral reticular changes with some traction bronchiectasis and evidence of a post-infectious fibrosis. So these patients aren't necessarily common, but I think there are certainly cases where people will develop more ongoing respiratory complications related to their initial COVID infection. So I'll leave it there, and many thanks to everyone, particularly the people whose brains I picked to give this talk and whose data I explored, and who've done enormous amounts of work to support the service during this difficult time. And I echo previous people's observations about how amazing our colleagues on the ward, the allied health nursing staff, our scientists have been to allow us to look after these patients. Thank you.
Thanks so much, Celia. So we might move straight along to the Q&A section, and I'll just ask all our panelists to turn their videos on and pop this on there. So thank you everybody for submitting questions. We've got quite a few. I might start off all by asking a question from Simon Macklin, who asked what was the buy-in from other procedural teams with donning and doffing and theatre isolation times?
The buy-in was absolute. It's hard to describe the feeling that was around, particularly in theatres at that time, but it was a feeling of apprehension, of fear, and of wanting to protect oneself to the best that we could provide. So we had no issues whatsoever with compliance. The only reason someone wouldn't apply the appropriate PPE is if they didn't know what they should be doing for a given case. So the emphasis wasn't on needing to convince people, it was on just education around what was required and what the process was.
Great. The next question I have from Simon Jenkins, perhaps for all of our panelists, who thanks everyone for their presentations. In his institution, SCOVID can be considered to apply to any any patient with fever or respiratory distress presenting to the ED. Is this the same cohort that you experienced, or did you narrow it down a little? And perhaps I'll ask Claire to start off with. I'm sure you got lots of phone calls about this, Claire.
Most of my day. The criteria for SCOVID was actually much broader than that. It was any respiratory symptom, anything, sore throat, runny nose, whatever. And we also had other additional criteria. So if a patient coming in who was unconscious or couldn't give a history, we SCOVIDed them as well because we had no idea whether they had any respiratory symptoms. We also had a slightly lower threshold for testing in the elderly. We now know that the elderly present with more vague symptoms. So they might just feel tired. They might just feel run down. They might just be a bit confused. So these patients were all SCOVID. So we really had a low threshold for testing. And whenever we test anyone, they become SCOVID, because we really didn't want any staff or patients to be inadvertently exposed to these people. So we tested broadly. And when we got a negative result and it was appropriate, we cleared them as soon as we could. But it was a much broader testing strategy for fever and respiratory distress.
Mm. And
sorry, I might just add into that, if I may, and it's a good point to make. I think it means, particularly, for example, in the respiratory unit, that a very large proportion of our normal business now comes through emergency with a SCOVID label. So having a functional way to deal with that so that care, you can keep providing usual care right from the moment they come in, as opposed to waiting for them to be cleared, is an important part of the flow, and good testing and good communication.
Thanks for that. Probably a follow-up question then is that, so understanding that the intubation team took care of all COVID and SCOVID patients in ICU and ED, did this mean that all ED presentations requiring intubation for respiratory distress were intubated by the COVID team, or were you able to narrow down the numbers a little bit?
The vast majority where a history couldn't be taken were managed by the intubation team. As I said, ICU activated the team, and we came when activated by ICU. So if there was a clear non-COVID reason why that patient had deteriorated, and I can't think of a specific example, but an instance might have been someone who'd come in with headache and then had collapsed from an obvious, suspected subarachnoid hemorrhage. I don't anticipate we would have been activated in that instance, but we certainly intubated a number of drug overdose patients because simply a history couldn't be taken.
And I'd add to that, Simon, and say that I'd say probably 90% of the time we would be activating the COVID intubation team in those scenarios. But it was very much a multidisciplinary approach along with the ID physicians. We've got an interesting one from Kerry Skinner, who asked, perhaps again, probably directed more towards Claire, what was the percentage or how many healthcare workers caught COVID?
Oh, sure. So we're actually sort of putting this together for publication. At our institution, there was roughly 50 that acquired COVID. We went into their history very carefully to try and work out if it was community acquired or hospital acquired. To bear in mind, a lot of our staff members were in hotspots and we had a lot of community transmission. And probably about 19 were, we think, healthcare acquired. So about half were acquired in the workplace. We had a significant outbreak on the non-clinical areas of our COVID wards. So the ward tea room, about 10 people were infected through that. So which leaves us with about 10 staff members who we believe acquired COVID in the workplace. A couple of them reported obvious PPE breaches, or we knew that they weren't, later on we found out they were perhaps having difficulty with PPE, like so major PPE breaches, you know, taking the mask off, using the phone on the COVID ward, that sort of thing, and which left us with about 6 staff members who had really good PPE practices, and we couldn't pin down a reason for why they got COVID. All of them were working on the COVID ward or in the screening clinic, so certainly they were in our high risk areas, but they were the ones we just couldn't find a reason for them getting it. And I think that just really speaks to how risky it is to work with these patients and how important it is to put as many of these practices in possible to reduce that number down to 0, because we really don't want any staff members acquiring COVID in the workplace.
Absolutely. We have quite a few questions around the topic of palliative care. And perhaps to summarise them, I think I wondered if each of you could comment, first of all, about the decision to offer palliative care. What was the decision-making process? And then were there specific initiatives that were triggered to include family members and honour the patients at the end of their life?
I'll start, but Claire, I guess it's an incredibly difficult and challenging area to speak to or to experience. I guess on my time on the ward at various times, I didn't personally have to be involved too many times, so Claire might have a different experience. But I think the staff moral distress, the conflict between the limitation of visitation and to only really the final terminal phases of care was just distressing to conform to, and put a lot of pressure not just on the medical and nursing staff, but the administrative staff, anybody who had to communicate that or deal with distressed families. Was a very challenging area. Having said that, I think people did amazing things and good work to do their very best to allow communication and contact where appropriate and possible. And the specifics of it in either the ICU or the ward settings were very much individual case-by-case scenarios. But indeed, that question, regardless of COVID, just because of the visitor policy to the entire hospital, affected every non-COVID patient, every routine issue. And it wasn't until, at the height of the pandemic that you were really in the terminal stages where there was some flexibility to get some improved bedside contact. Sure whether others have got more to add.
No, I absolutely agree. I think we should mention the role of the palliative care unit in all this. They really did guide the COVID unit through a lot of these discussions, had a lot of processes in place. And, at the height, it really was just a lot of emotionally draining work for the staff, particularly the junior doctors, to have to keep communicating with families. And so they really helped out in that instance. But the palliative care unit was part of the COVID unit. I'm sorry that I haven't mentioned that before now, but they attended a lot of the handover meetings and were really on top of things and helping out in best possible, but it was really challenging.
That's a good point, Claire. They were actually, they became embedded in our communications, and we should acknowledge that. They were critical. And
it also, we had the general medical team involved as well, and the Jerry's team. So the teams are really highly skilled in dealing with these difficult situations. So it just speaks to, we need a multidisciplinary team to do what's best for patients and their families.
That certainly seems the theme of everybody's presentation today. Just a couple of questions, we'll just try and squeeze them in. One from Andrew Bowie just asking, do we know how many COVID patients required emergency or semi-urgent surgery, and how did they go post-operatively?
Claire might have an exact number. My recollection is 3. They were for very minor procedures, sort of minor plastics procedures unrelated to their COVID presentation. Although we were prepared for, an unwell COVID patient maybe needing to present for emergency surgery, possibly for, a bowel obstruction or something like that, it didn't eventuate.
Yeah, I'd agree with that. The 2 that spring to mind, we didn't pick them up as being COVID positive until after the procedure had happened. So because they either just didn't have any symptoms when they came in, or the screening mechanism failed to detect that they had very mild symptoms. So we didn't really need to operate on someone who was COVID positive. I had one question about someone who had recovered from COVID but now needed to have shoulder surgery because they fractured their humerus, but that was 2 months after they had the infection. So that was a very easy, yes, they've totally recovered, please proceed with the surgery.
Great. There's just a question about elective surgery as well. Louise, I wonder if you might be able to talk to what happened to elective surgery and what categories of operations you performed.
Yep. Early on in the first wave, we went to category 1 and urgent category 2s only. Then there was a DHHS driven requirement to reduce across the board the amount of surgery being done to various percentages. So at lowest, we're operating at about 50% capacity, and then that steadily increased. Certainly one of the challenges for us throughout this as an anaesthetic department was maintaining that balance between COVID readiness and business as usual. So yeah, at times throughout the year, we had the luxury of not having to do as much elective surgery and therefore being able to staff a 24-hour intubation team for 5 months. But then, even as the second wave was still underway, we were getting back towards business as usual.
Great. I think we might need to wrap up things there. I'm just mindful we've well gone over our allocated time. So I'd just take the opportunity to thank all of our panelists in this first session again, to Dr. Gordon, Dr. Lanteri and Dr. Ellard. Thank you so much for all of your time. I've really learned a lot, even though I was working with all of you during that period of time. So thank you so much. And thank you everybody for submitting your questions. I'm so sorry we couldn't get through them all, but we'll try and type some answers to some of them perhaps during the next break. Thanks, Shiva.
No, thank you very much. We've gone about 20 minutes over, so I'll give you 5 minutes. So try to make it up. We may not be able to make some time there. Thanks a lot.
No, it's not so hard.
Thanks for the second session, and we had a very good response so far. And I'll just let Jo go ahead with this. Thanks, Jo. Go ahead.
Thanks.
Jo is one of our intensive care senior registrars, and she has kindly accepted to chair the session.
I'd like to welcome everybody back to session 2 of today's webinar, and I hope you've been enjoying the symposium as much as I have. So I'm Jo, I'm one of the ICU senior registrars here at the Austin, and I'll be the chair for this session. I'm extremely honored to introduce 3 very distinguished speakers who are very much valued and respected ICU colleagues. They're Doctors Lucy Modra, Jane Lewis, and Emily C. And so similar to session 1, attendees will have the opportunity to ask questions, put them in the Q&A box. We'll try to get through them, and we'll get to them in the Q&A session after all the presentations. So to start things off, I'd like to invite Dr. Lucy Modra to enlighten us about playing battleship and managing the COVID ICU. Lucy is an intensive care consultant at Austin Health. She's a PhD student and a senior clinical fellow at the Center for Integrated Critical Care at the University of Melbourne. She was awarded the Don Harrison Prize Medal in the College of Intensive Care Medicine Fellowship exam for the year 2015. That same year, she also co-founded the Women in Intensive Care Medicine Network, which is now formally affiliated with the Australia and New Zealand Intensive Care Society. Welcome, Lucy.
Thanks very much, Jo. Okay, I'll just ask you to indicate when you can see my slides, please. Is that all looking good? Wonderful. So thank you for the kind introduction. And I'll be discussing the idea of playing battleship in a COVID ICU. And in particular, I'd like to bring to this talk the lens of crisis resource management principles, which are probably familiar to particularly, I guess, the anaesthetists amongst the attendees. And I've highlighted, I think, some of the more relevant crisis resource management principles here, which I think were really drawn upon to address these specific challenges we faced in organising the ICU pandemic response. And throughout my talk, I'll invite you to play pandemic bingo, which perhaps will also be relevant throughout the rest of the sessions as well. I think in particular, I found myself almost getting to the point that I cringed every time I used the word iterative this year. And yet I think it has been a useful concept. So the first, in March of this year, it became clear that we needed to anticipate potentially a very large surge of patients with respiratory failure requiring intensive care support. And a key challenge would be simply beds. Where would we put all of these patients? Now, I think Louise has already highlighted that a strategic decision made early on by the DHHS in Victoria was to limit elective surgery, greatly reduce the volume of surgery that was occurring in our operating theatres. And this really facilitated then the key decision that we would plan, if needed, to use the spaces in the recovery suite, the operating theatres and the surgery and endoscopy centre, all of which at the Austin are geographically both located on the same level. And so this was essentially one of the versions of planned ICU surge capacity or demand-based escalation, which you can see culminated in up to 100 beds in our ICU. For context, we are funded for 23 full ICU beds. We physically have 29 bed spaces, and of those we have 4 isolation beds, which is pretty common amongst ICUs that have probably been built more than about 8 years ago, this relative paucity of isolation bays. I think, really quite almost horrifyingly, quite early on in the pandemic, even whilst we were planning to potentially expand to 100 or 150 beds, it was being projected by some epidemiologists that we would only be able to accommodate 1/3 of patients requiring ICU care. Now, happily, we didn't get there. And I think that's really a credit to the public health teams and the government who listened to those public health teams and the public who responded. So we really got to a stage 1 of this model where one of our pods, Pod C, became a dedicated COVID-SCOVID area. And this then necessitated that we open up some beds within the surgery and endoscopy centre in order to accommodate the non-COVID patients. At the same time that all this was happening, you've heard about some of the other changes that were required in the hospital. And this included, for example, the splitting of our emergency departments into dedicated COVID and non-COVID emergency departments, and how to safely move patients through the hospital in such a way that COVID or SCOVID patients were not unnecessarily coming into contact with other patients. And so one of the hallmark things we've had in the ICU is this orange light alert system to alert people when our single access corridor is accommodating a COVID transfer. I'll just touch briefly upon this. The other really obvious thing early on was that we would potentially need a lot of new equipment, most notably beds, ventilators, and some new ECMO machines. And once we were able to acquire these, with the DHHS, then they needed to be stored somewhere. And essentially there had to be a rapidly repurposed area of the hospital to store this equipment safely. And so whilst I think there was a lot of focus on ventilators, there were other shortages that really, potentially took us by surprise. And I think this highlights another lesson for me, which is, the experience of the pandemic was the challenges that you saw coming and the challenges that you did not see coming. We, at one point, were thinking we would have to triage the use of waveform capnography because of a shortage of the waveform capnography monitors. Many of you will have been aware of the shortages of various neuromuscular blocking agents, and our pharmacy team were great in sort of helping us to provide a cheat sheet on which neuromuscular blocking agents we should try and use in order to reserve specific things like cisatracurium for cases that genuinely needed that specific drug. And one moment that really will stick with me is on I think a busy afternoon in late March, I saw one of our senior nurses looking quite busy and stressed in our equipment rooms, and she had just identified a hospital-wide shortage of the nozzles that dispense debug or hand sanitizer, which really effectively renders the actual bottle and hand sanitizer useless if you can't safely dispense it. And so, as I've said, I think in the media there was at the start a real focus on equipment and ventilators, yet over time there was a realisation that the ventilators do not run themselves. You really need adequately trained critical care staff across craft groups. So not just doctors, but nurses, allied health, and the support staff. So this brings me to the staffing model, and I think this presented both challenges and opportunities. The challenges were that at times we did have staff quarantined or you know, on a sort of a mandatory furlough due to inadvertent potential COVID exposure. We also noticed a real change in practice around taking sick leave. I think this year it's become clear that I think quite appropriately it is inappropriate to attend work if you have upper respiratory tract symptoms. But it's worth acknowledging that that probably is a change in practice, and it did mean that we experienced more sick leave than we have previously, as people were appropriately not attending work when sick. The increased and changing number of beds and bed configuration necessitated more staff. So at times we had sort of an interesting situation in that we had a dedicated COVID and SCOVID pod that wasn't always full. At times it had a few patients in it, and yet clearly for infection control reasons, this was necessary. It meant we needed to have another location to care for other patients, and therefore we needed, you know, critically care trained staff to care for those patients that were actually out of our unit and in what is normally sort of the recovery surgery endoscopy area. The staffing model, we also noticed that we had to account somehow for the decreased efficiency of our staff in performing their normal familiar procedures due to the challenges of PPE. And we've heard about the sort of pauses required for air handling, aerosol generation procedures, but even simple things like donning and doffing PPE safely to do things like, for example, insert an arterial line and a central line in a suspected COVID patient certainly put an impact on our workflow. We had to consider how to deploy higher risk staff members. So for example, those staff members who were pregnant, older in age or immunocompromised and therefore at higher risk of severe coronavirus disease. We attempted to improve after our senior staffing because we currently run really quite a lean model where there's an intensivist on call overnight who is the intensivist who will continue to work during the week and do the ward rounds. And then I think the real opportunity that Louise has already highlighted was that we were able to work alongside our colleagues from Anaesthesia, both from the junior medical and senior medical staff, in order to bolster the skills and staff the additional pod that we needed to run. So crisis management, advises us we need to know our environment, and this includes knowing our team's strength and distribute the workload. And I think a really nice example of this was the early deployment of our physiotherapy team, in particular our senior ICU physiotherapists, to lead the proning service. And in many ways, this reflected the work done by Anaesthesia to develop and lead a COVID intubation service, including developing simulation training, multidisciplinary training, and ensuring then that not only was this an efficient way of training people, but proning itself is quite a time-consuming task. It requires a number of skilled clinicians to enter a bay fully PPE donned. And this was one way of, removing the potential workload from the ICU doctors and nurses in a very efficient manner, and allowed our physiotherapists to work very comfortably within their skills and expertise. So then the next challenge was, developing appropriate clinical treatment guidelines, both for in recognition of the specific aspects of management of COVID-19, but also the aspects of simply delivering critical care per se in the pandemic situation. And there's just this absolute explosion in consensus statements and guidelines. And I think philosophically this really raises an interesting tension during the pandemic, which is the tension between personalised medicine and the sort of cookie cutter style efficiency of very protocolised medicine. And I think in intensive care, we more commonly err towards the former, that we rely on quite a consultant-led service that routinely develops sort of individualised treatment plans based on, based on the evidence for that condition. And yet in a pandemic, it suddenly became clear that we may potentially need to rely far more heavily on protocols, because potentially we'd be in a situation where there were junior staff or senior staff working sort of slightly beyond their normal scope of practice, performing less familiar aspects of care. We needed to be able to deliver care in a standardised fashion, anticipating that we may not have the intense oversight of all our ICU patients that we normally do. And we also recognise that protocols can help clinicians who are under the substantial cognitive load of a pandemic. But there are limitations to this response. I think insisting on very rigid protocols can limit the relative benefit of having senior expertise. And the other limitation is that in a pandemic situation, as we've all experienced, the protocols change very quickly. And so here is sort of an absolute caricature of the practice of anaesthesia, which I think I might have been told when I was a medical student, the idea that you do, you give a big syringe, a little syringe, and then you put a tube in. And I think further looking at this, Dr. Ellard and an anaesthesia team caring for a liver transplant patient, I can guarantee you that I don't think they're thinking about this protocol here in delivering the very personalised care that is enables us to get really high quality outcomes for this type of complex patient. And so, what's the answer to this tension? I think, as has already been highlighted, it's probably simulation driven and iterative guideline development. So developing a guideline both in response to rapidly repeated simulations and also real-time audit, which I think was really nicely rolled out by the anaesthesia department with their COVID intubation team. That guideline was refined very rapidly. Again, with this sort of explosion of guidance from all sources, really, I think one of the things I noticed at the peak of the pandemics was this sort of sensation that when I checked, if I had time to check a news website, that would be in some ways just as likely to deliver information that may impact, my practice in the hospital, because that's how quickly information was coming out. And one of the things that, quickly became evident that in-person meetings, as you can see here on the left, sort of whole team meetings would be unacceptably risky to continue doing that IRL meeting. And so there was a very rapid rollout of Teams to enable video conferencing, which I think was crucial. The other thing that worked really well for us in the intensive care was adapting an existing process to disseminate this rapidly changing information about the pandemic and guidelines such as changes to visitor restrictions or PPE. And that is that we normally have a twice daily huddle in the ICU, which is attended by all the ANUMs and consultants who are on clinical duty. The purpose of it is to quickly audit the patients in our unit, those who can be discharged, those who require urgent transport. And this was then leveraged to be the forum in which we could have at least twice daily updates of the clinical leaders who were on for that day about crucial new information. And here's a photo of, our a whiteboard that, I think in 2019 relied upon very heavily in the huddle. That was, quite fun to be able to move the coloured magnets around in a game of battleship. But now, in fact, we're doing this very effectively over Teams in a similar fashion. And so then that brings me to another form of really challenging communication during the COVID pandemic, which was the idea of family meetings and communications with families and relatives during the pandemic. So for many, many weeks this year, we had periods where per DHHS guidelines, we had no visitors attending ICU, regardless of if the patient was COVID, SCOVID or non-COVID. And the only exception was sort of a compassionate exception for patients who were in a terminal phase receiving end-of-life care. And this was a major change in practice for us in ICU. So I think in usual times we would encourage family members to attend, sit at the bedside, during daily visiting times. And during this time, actually the family member has a chance to see for themselves and adapt to the idea that their relative is critically ill. They also have an opportunity to witness the care, and in particular the sort of intensity of care that is provided by our intensive care nursing staff. And this in turn, I think helps the relatives build sort of rapport and trust, and incrementally ask questions over time of several staff members, So they'll often get bedside updates from a doctor, a nurse and an allied health team. And I think this is particularly important for, that smaller group of families whose relative patient has a poor outcome from ICU or dies following ICU treatment. I think it's a sort of a trope in intensive care medicine that the relatives who have had the opportunity to attend ICU and had a chance to adjust to what's happened to their relative are often more understanding if we're in a position that we need to deliver the bad news that, escalating treatment is not working. And the classic trope is a relative who's not had that opportunity. They may have flown in from interstate or overseas, who is blindsided by this news, doesn't have that pre-existing rapport and trust in the team, and they'll often be the one who feels compelled to advocate for ongoing aggressive treatment, even whilst their relatives feel that they can see that this burdensome treatment is no longer helping. And suddenly I think we found ourselves in the position where all of our relatives were the interstate relative who didn't have a chance to witness this journey. And I think, as has already been mentioned, this really took an enormous emotional impact on most of all the patients and families themselves, but then also all of our staff, and including even, like, for example, the staff who manage our, the phone calls and usual visitor access. And so we actually we routinely hold multidisciplinary clinical ethics sessions in our ICU, which is a chance for us to discuss sort of thorny or challenging ethical aspects of treatment. And we had one dedicated to discussing the clinical ethics of visitor restrictions. And the striking thing for me was really just the depth of emotion and concern displayed by all clinicians who attended this session, with the commonest sentiment expressed being that this was the worst aspect of the pandemic for them. I think we had one senior intensivist share in that session that it was one amongst the worst days of his clinical career, when he needed to provide end-of-life care for a patient who hadn't been able to have their relatives attend throughout their ICU admission. And I think that type of session was actually very powerful. I should say it was held over video conference. It was very powerful in seeing for the more junior staff members to see that even very seasoned, experienced clinicians experience moral distress from this requirement of visitor restrictions. And yet it must be acknowledged that some of the potential moral distress and moral injury we anticipated, we did not experience, and that we were saved potentially the worst of it, of triaging patients who would be allowed into ICU to receive ICU care. So the key lessons that I think I'd like to highlight from the ICU's response is, where possible, try to adapt established routines and processes to work with the familiar as much as possible. Know your team and allow them to work to the peak of their expertise and skills. Balance protocols with personalised medicine. Expect the unexpected. And finally, never waste a crisis. And I think there has really been some positives to come out of the changes this year, including video conferencing, the use of interdepartmental and multidisciplinary simulation, interdepartmental cohesion, and also, really substantial media opportunities for different departments across Austin Health, which I think is a positive. So thank you for your time. That's my daughter having, I think, her 4th COVID swab for the year. And you're welcome to email me with any questions. Thank you for having me.
Thank you so much for that, Lucy. I'd like to invite now Dr. Jane Lewis, our second speaker, to share her experience with us about ICU respiratory care. Jane is a respiratory and intensive care consultant who trained in the USA. She then met and got married to an Adelaide anaesthetist. She has been in the Austin ICU since 2015 and is one of our supervisors of training. She also works with Donate Life as one of the medical consultants for organ donation for the state of Victoria. Her interests include anything related to respiratory ICU medicine, end-of-life care, and organ donation. Outside of work, she has interests in Lego, cars, insects, and anything else a 7-year-old boy might love, in addition to travel and books. Welcome, Jane.
Thank you, Jo. I am going to try and share my screen, so apologies if it doesn't quite work. Hold on. Share. And play. Can you just let me know if it's working?
Yes, it is.
Oh, fantastic. Thank you. Thank you, everyone, for inviting me to speak, especially Shiva, who's done this organising, and all the other speakers. It's actually been fascinating listening to everything. And I wanted to actually say that even from my perspective and my talk, it's been kind of a fascinating reminder of the last 6 months. And I think we forget what we've been through. We're very good at putting these in boxes and dealing with them later. And so going back and looking through my emails and looking through the protocols and looking through all the things that we were doing back in March was just fascinating and interesting. So it's actually been personally and professionally very interesting for me. So my sister is a high school science teacher. She works in the USA. And so believe it or not, she believes in science. And we were having a conversation the other day and we were just talking about science. And she was saying, as the evidence changes, so should our practices. And I think this is something that actually has been key to the last 6 months in a huge amount of change that's happened. And just trying to keep up with all of the changes and all of the information and trying to apply it and make sure that you disseminate and communicate all this information effectively in a timely fashion and in multiple ways to do that. So as most of you know, America's about to have just completed their Thanksgiving. Today is Black Friday, which is the biggest shopping day of the year. And as you just noticed for the airports from Wednesday, Thanksgiving has definitely been an interesting experience. And unfortunately, I think we're going to see a lot higher numbers in the US in about the next week or two. So for me, this was my personal life in early 2020. So in February, we were looking at going to the USA to visit my family. Mum had been unwell. She's fine, but I really wanted to go visit her because my family live in the US. We decided that pulling our little boy out of school for 10 days was not ideal. So we were going to delay the trip to the March school holidays, which makes total sense until you throw a pandemic into the mix. And I happened to wander past Professor Ronaldo Bellomo's office one day, and Paul Johnson, who's one of our professors of infectious disease, was having a conversation, and we were talking about, in general, the pandemic, and the conversation came to the fact I was planning on going to the USA to visit, and was strongly urged to reconsider that, and was told that actually our insurance would not cover us if we got COVID, and the hospital was about to put in some strict recommendations. So all of this happened incredibly quickly. I know everyone remembers this, but it's kind of interesting to go back through that journey that we went through. And then we had also March 12 to 15, we had the Australian Grand Prix, and it was my father-in-law's 80th birthday. We were going to go and have this. We planned this for about 6 to 12 months. Interestingly, or appropriately, is the better word, it was cancelled at the last minute, but it was literally the last minute that was cancelled. And then for those of us who have children at school, school holidays hadn't started yet, but all of a sudden we were having to transition to the last day of school at school, and all of a sudden you were doing school from home. So there were lots and lots of changes, both personally, as I've described for me, and I know everyone has gone through this, but now we actually go into the professional side of things. So here were the massive changes that we went through. So we had discussions about oxygen therapy, intubation, mechanical ventilation, and thank you, Dr. Louise Ellard, for all the information about the intubation COVID teams, high flow oxygen therapy that Dr. Celia Lanteri mentioned, non-invasive ventilation, ventilator splitting, bronchoscopy, and even proning. So going back through this, this was sent out by the head of our respiratory unit, Dr. Christine McDonald, towards the end of March, after we had had an organizational and collaborative approach, which is tricky, as I'm sure you understand, trying to discuss with different departments, with rapidly changing landscapes of evidence to figure out how best to take care of these patients. So we decided for these patients that they could have low flow therapy. So as you see, nasal prongs up to 4 to 5 litres per minute, or if they're lucky, a Hudson mask up to 8 litres per minute, which is still very low. If these patients were hypoxemic, and if they weren't able to maintain an oxygen saturation that was deemed appropriate, then they would be brought up to ICU, or if they weren't for ICU, then discussion was held with the respiratory registrar. Interestingly, we documented that for patients who are candidates for ICU, there was absolutely no role for high flow nasal oxygen. And quote unquote, high flow oxygen should not be used routinely because of risk of aerosolization of virus. So as you can imagine, this led to different practices that we normally would do. So we were intubating patients early, and we can talk a little bit more about that. I will add that a lot of these are going to be emails that were sent by me, and part of the fun of what I had to prepare for this talk was just actually go through my emails and review everything that was sent and what we were talking about. I was quote unquote the lucky one that I got to do all the emails regarding to anything respiratory in ICU, because that's my portfolio and my area of interest, clearly, as a respiratory physician as well. So at 6:20 in the morning on a Saturday morning, please don't ask me why I was awake, but as you can imagine, a lot of these conversations were being had, and it did disrupt our sleeping patterns, and it was really important that we disseminated this information. We sent out this email. And as you notice, again, it's exactly the same thing that we just talked about no high flow oxygen, no non-invasive ventilation, et cetera, et cetera. And these were the guidelines that I developed along with everyone else that we've been talking about at the Austin, and actually external to the Austin as well, talking about how we manage these patients specifically from a ventilation standpoint. So we actually did early invasive ventilation, and I'm still trying to review all the literature as to why we pushed this so hard. Why did we avoid high flow nasal oxygen, which is clearly the change that we've noticed in the last 6 months. And my understanding again was that we felt that high flow nasal oxygen was unsafe, and that a closed ventilation circuit was the safest way to protect our patients and staff. We did not want to use nebulizers, I apologize. Non-invasive ventilators were not indicated. You can see there's lung protective strategies. Lungs like to be dry. We would minimize our inhaled nitric oxide and epoprostenol. And that was really partly because we didn't have that many circuits. And as Lucy mentioned previously, equipment was a huge issue for us. And so we had to actually look at minimizing our resources to ensure that we had the resources available for everyone as required. Interestingly, and Dr. Emily C. is going to talk about this soon, is that steroids for refractory shock only, and there was no clear benefit at this time for ARDS. So this was pre the recovery trial. This was actually released back in March 18 of 2020. The problem was, as everyone has pointed out, is that it was a rapidly changing landscape. So where did we get all our information from, and how did we proceed? And so there was the Australian Living Guidelines, which were fantastic. There was the eSICM. I'm American trained, so CHEST and ATS. In addition, there were webinars that were being put on, both from personal experience. I listened to one from a doctor who had traveled from the Midwest to New York City at Columbia to be part of their team, where they had about 250 patients who all had COVID and were ventilated in an ICU setting. We had Facebook pages, we had Teams, we had multiple sources of information. As Lucy pointed out nicely, the news actually was probably one of the best places to get the information. It was always fascinating, but I would end up on ABC News and get more information that was quickly released. And then I would note that it would follow in these resources. One of our biggest fears was, will we run out of ventilators? And looking back and knowing our numbers is a very different conversation to looking forward and trying to figure out if we truly have enough ventilators. So working closely with our VRSS colleagues, as well as our equipment nurses, our anaesthetic colleagues, we were trying to figure out truly how many ventilators we had in the entire hospital. And if you, excuse me, count them all up, you note that in ICU, we didn't really have that many. In 5 East, which is just another part of our hospital, they had a ventilator. Emergency department had a few ventilators. Theatres, we were looking at both our Austin theatres, as well as a separate campus called the Repatriation that also has theatres, and how many they had. And then our VRSS, which is basically our Victorian Respiratory Support Services, and they manage both non-invasive and chronic ventilator patients. And some of these ventilators that VRSS has are purely non-invasive ventilators. We also, with our equipment team, were busily trying to source ventilators. We were, along with the rest of the country, along with the rest of the world, trying to obtain all these ventilators. And we actually did get, I believe, about 15, and we were promised we were going to get them within the next month. And it took about 4 months for those ventilators to arrive. So we were looking at all these ventilators thinking, how are we going to manage it if we get an absolute explosion of patients who require this early intubation and ventilation support, and the numbers that were being modeled out of DHS and what we had seen elsewhere around the world. So we actually did consider for about 5 minutes, and it was actually longer than 5 minutes, but we looked at how we would be able to ventilate 2 to 4 patients on a single ventilator in case we ran out, so that we could continue to support these patients. And we were looking at 3D printing, we were looking at things that are already available and trying to jerry-rig different pieces of components. And we actually did come up with some ways to do it. Thankfully, we never had to even consider that. But interestingly, the Society of Critical Care Medicine, or SCCM, put out a consensus statement that said, please don't. It's too complex. You potentially could cause patient harm. And for us, we were in a situation that we had enough ventilators the whole time that we didn't need to consider this. Moving on, we then, if we were going to do early ventilation, then we needed to figure out how best to take care of these patients and our staff. And so one of the things that we were looking at is we needed the viral and bacterial filters. And interestingly enough, the amount of conversations we had both across the ICU as well as across the organization, including anesthetics, respiratory, was pretty intense, trying to figure out how best to do this. So where do we put the filters? What filters do we do? How often do we have to change the filters? When do we change those filters? What ventilators have inbuilt filters, and how long do they last? So as I mentioned, I was busy running around sending out emails. And one of the most challenging things I found with these guidelines and recommendations and emails was that words matter, and how you phrase something is actually very important, because you don't want it to be, what's the word? You need it to be specific. It can't be ambiguous in any way. So this was an email that I sent out on Sunday, right around the beginning of the second wave, looking at what ventilator fleet do we have and which ones do we use and how best to use them. So we're lucky we have some Draeger V500s that have an inbuilt HEPA filter, and those HEPA filters last for 7 days. We also had some Savinas, we also had some Avias that have an inbuilt filter that are fantastic, that they last 14 days, but we didn't want them to be used in isolation bays for other reasons. And then we had other filters, including McKay's, that had filters that needed to be changed at 48 hours, and the rest of them needed to be changed every 24 hours. And so, as you could imagine, the complexity of this about who changes the filter, when do you change them, how do you keep your staff safe, do you paralyze the patient before, do you clamp the tube, what do we do with all of this was quite complex. Again, we were very privileged that the majority of our patients could actually be on the inbuilt filter ventilators. The other thing that we got caught out was we would put an HME filter right at the end of the endotracheal tube after intubating the patient, and then we would have to swap them across. And if you didn't change the filter and then you tried to suction the patient, clearly you weren't able to do that. And so there was a lot of learnings that we had that simulation assisted us in figuring out, and then real life as well. The other thing at this time was related to the PPE of our patients was that our staff were in surgical masks in this closed circuit environment that we had hoarded a certain part of our ICU unit, Pod C. And then our patients were in surgical masks unless there was going to be an aerosol generating procedure of any type. And the concern was, and it happened, that sometimes the circuits would pop off and then all of the virus particles would be released into the environment. And so figuring out how best to secure your tubing whilst also allowing you to be able to disconnect as appropriate if your patient was deteriorating. And that was quite challenging. And so one of our educators and one of our equipment nurses sent out these pictures just showing how to sleek it, but also where not to sleek or intense sticky tape the circuits. So Dr. Lucy Modra mentioned the flip team. These are slides courtesy of Tom Rollinson, who's one of our lead ICU physios, and this was an amazing dedicated 24-hour service to provide proning to our intensive care unit that was physio-led to take some of, to provide a collaborative environment and also to take some of the load off everyone else. And so they were running simulations. We would do it early. This is based upon the proning study that was released previously. And we tended to prone quite early. And this is the team. You can see Tom on the far right. But basically, it was an amazing 24/7 service where a physician would be at the head of the bed. And otherwise, it was run by our amazing physio team. And that's, I've mentioned a few, the bronchoscopy and the mechanical ventilation protocols. This doesn't include all of the other ones that we haven't even talked about. So we had an extubation protocol, we had a tracheostomy protocol, we had an intubation protocol, we had a MET protocol, code blue, the transport protocol, which was really important that we had an organizational approach because these patients didn't just come up to the ICU. A very few of them came up to the ICU. The majority of them went up to the ward. And how do we do this efficiently, effectively, and safely for both patients and staff? And then the PPE, as everyone is aware, continues to change and evolve. And there were so many more that we haven't talked about. Back in March, this paper came out. Many of you know Forbes McGain. He's a critical care doctor at the Western, and he and his team looked at aerosol generation in patients who didn't have COVID because it was an N of 1, but he looked at just aerosol generating bits. It's not the technical term, but I'm sure you understand what I'm trying to say. So what he looked at was how much aerosol generation occurred when you were breathing, when you were talking, when you were coughing, when you're on humidified nasal prongs, either at 30 litres per minute or 60 litres per minute. His non-invasive ventilation, you note, will have a much increased amount of aerosol generation, as well as the nebulizer. What is important to know in this study is that the non-invasive mask that was used was actually created to be a very leaky mask, and so had a nasogastric tube specifically to make the worst case scenario of a leaky mask. And then you note that nebulizers are bad, as we all knew. Going back to that though, it really was a team approach. So we had a patient in the ICU who I was on service, and we extubated her at 15 days, and she developed stridor after extubation. And so the initial thought was, well, grab her some adrenaline that's nebulized. And the nurse actually turned to me and said, but Jane, your guidelines recommend against using nebulizers. And I had to say, oh yeah, that's right. We are in COVID. That's exactly right. Thank you for letting me know. And it's one of those that it's so vital for everyone to know exactly what's going on, because you think you know what you're doing, and then you get caught out on something that to me was just kind of an immediate response to stridor. The patient did well, did not require reintubation, and went to the ward. But it's one of those that I kind of have to sit there and smile and say, thank goodness for people to ensure that we are all taking our best care of our patients as well as ourselves. So at the beginning of the second wave, with all the data that came out, including the living guidelines, it was deemed that high flow nasal oxygen was more appropriate and safe for our staff as well as the patients to continue. And there was some early data that came out of New York that said anyone who was mechanically ventilated had an incredibly high rate of mortality. The data since that time isn't nearly as high, but again, the recommendation is that we're going to do exactly what we normally do. And that's really the crux of my talk. So back in August, at the beginning of the second wave, we were talking about using high flow nasal oxygen. We were going to recommend the lowest flow rate and place a simple surgical face mask on the patient if we could. Interestingly, you'll note that I also document or mention about non-invasive ventilation if required. And that leads on to non-invasive ventilation in ICU and how much discomfort there was from our staff. From a safety standpoint, everyone was highly concerned about this and felt that this was a very, very unsafe thing for us to provide. I will add that we didn't actually end up providing non-invasive ventilation. I know that VRSS did, which is another part of our ward that supports chronic patients on non-invasive. But for us, we were just being prepared. DHHS sent out this guideline back in June that basically described how to do it. And it was very similar to the intubation protocol that we had, where we put the non-invasive ventilator mask on and then we would turn on the machine to minimize the risk of a leaky seal and aerosol generation. And then filters were very important. This is the VRSS guidelines, and you'll note that that's a machine that we don't use in the intensive care unit, but the recommendations remain the same, which is you would have both a filter, bacterial and viral filter, both pre and post essentially. Last but not least, something I'm very involved in is bronchoscopy in the intensive care unit. And as you can imagine, there are recommendations not to do it because it's aerosol generating. So the recommendation, and you can see this is from the beginning of March, was that we shouldn't be doing it to diagnose COVID-19. I think that's a fairly no-brainer. The AABIP, which is a US interventional pulmonary group, put out the recommendations that we don't do that as well. It's relatively contraindicated. Going back to the importance of an organizational approach, we had long conversations with the respiratory unit so that we were in line with them. They were following similar recommendations, so that it was a similar approach across both. Interestingly, this was at the beginning of the first wave, and we had a situation that we had a patient who was a spinal patient who'd been in hospital for about 4 weeks, so pre-pandemic times, who had a thick secretions and was undergoing bronchoscopy essentially for pulmonary toileting, and had no risk factors for COVID. So I love bronchoscopy. I volunteered to help out a colleague and did the procedure at the bedside with usual precautions, which for ICU was a surgical mask. And the next day, his wife was admitted to the Austin for pneumonia. And so she ended up being ruled out for COVID, which she was, but that meant that he had to be ruled out for COVID. And all of a sudden, the realization of community transmission, and this was when we allowed visitors in the hospital, was massive for staff safety as well. And so we elected to say that no bronchoscopies in the intensive care unit, regardless of COVID status. even if you believe that they had no risk factors, needed to be escalated to a consultant and decided if we were going to do it. And if they were going to do it, we recommended doing it as safely as possible, ideally in a negative pressure room, limit the number of people, i.e. don't make this a teaching session, have, you know, the nursing staff away unless it's required, and keep it as safe as possible. So in conclusion, is it really any different? And what lessons have we learned? And I'm going to tell you, I've learned a lot, and we've learned a lot. We know this, but science is ever changing, and keeping on top of it is incredibly difficult and challenging. And I think one of the things that really helped was that we had an organizational approach. We had multiple people involved. I would encourage anyone to email me any updates or recommendations that they had, because I personally couldn't keep on top of it, and I don't think anyone could. The organizational approach is ideal. We found out before the second wave that high flow nasal oxygen is safe. Early intubation for hypoxemic respiratory failure is not necessary, and in fact may be harmful. We really want to avoid bronchoscopy and any aerosol generating procedures, including nebulized adrenaline. And this was really my take home, and something that I talk about regularly, which is do what we always do. We need to do it well. We need to take care of the patient. But at the end of the day, although the mortality is high and there are complicating factors in terms of staff safety, it is really taking care of patients and doing the best that we can and doing what we always do. And we were able to do that because our numbers weren't escalating and massive. The other thing I rediscovered is that the world has gotten very big again. So thank you to everyone. I put a few people on there: Steve Warriller, Michelle Topple, who are our directors of the ICU. Christine McDonald is our head of the Austin Respiratory Department. I had colleagues in the US that I hassled, our infection control and infectious disease colleagues, specifically around how best to manage bronchoscopy, and our ICU department, which was fantastic, and the rest of the hospital. So thank you. And I'm jane.lewis2 if you do want to email me. So half my emails don't end up in my inbox. So thank you.
Thank you so much for that, Jane. It was interesting to see some other users of the sleep tape. Okay. So we'll move on to our third panelist today, and I'd like to invite Dr. Emily C., who's our intensive care fellow, to tell us about treatments for COVID and seeing the wood for the trees. Emily is a senior registrar in the ICU at Austin Hospital. She's a consultant nephrologist at the Royal Melbourne Hospital and a senior clinical lecturer at the University of Melbourne. She's also a senior clinical fellow at the Centre for Integrated Critical Care. She holds a Master of Evidence-Based Medicine from the University of Oxford and is currently completing her PhD in the long-term sequelae of acute kidney injury at the University of Melbourne. She's leading the national collaboration between NZICS and ANZSN to report on the long-term renal outcomes of COVID-19. Welcome, Emily.
Thanks very much, Jo. COVID-19 is an acute, non-specific respiratory syndrome, which is accompanied by a generalized inflammatory response caused by SARS-CoV-2 infection. Worldwide, more than 50 million infections and 1.3 million deaths have already been documented, and both of these figures likely represent a significant underestimation of the true incidence and burden of disease based on variation in testing and reporting practices between countries. Most patients with COVID-19 experience only mild symptoms or moderate illness, but as many as 10 to 15% progress to severe disease requiring hospitalisation, and 5% become critically ill. And this means that identifying effective and safe treatments for COVID-19 is a major research priority at the moment. As we're all acutely aware, there's been a large volume of research being produced at extraordinary speed during this pandemic. January 2020 saw a sharp rise in the number of publications relating to COVID-19, and it continues to grow. And this you can see in the figure from MJA in the top right. This has resulted in a rapidly evolving body of evidence to inform the treatment of patients with COVID-19. However, many of these publications reflect case reports, case series, and uncontrolled trials of experimental treatments. The evidence has generated an unparalleled level of interest from the medical and non-medical community, and many of the results from the important studies are featured in the popular press. This is a really good systematic review and meta-analysis, which is published in BMJ, and it's what's called a living systematic review. So it's regularly being updated in real time on the Magic app and also intermittently on the BMJ website to summarise available treatments and their evidence for each of the patient-centred and meaningful outcomes that trials have investigated. Generally, therapies for COVID-19 fall into two main categories. You've got antiviral agents and then anti-inflammatory drugs, which are designed to treat the massive amount of inflammation that patients with severe COVID-19 experience. And we're going to talk about a few of the treatments that have been or have the most evidence either for or against thus far. Starting with dexamethasone, which is really the most, I would say, important and evidence-based treatment for COVID-19 that we have to date. So this is a corticosteroid that we've used since the 1950s for all sorts of diseases, and we've got a lot of experience using it. The sort of idea behind its use is that the host response is believed to play a key role in the pathophysiology of organ failure through a SIRS multi-organ failure phenotype. Early evidence to support glucocorticoids came from the glucocovid randomized control trial, which found improved clinical outcomes with methylprednisolone compared to standard care. It was very small. It included 85 patients, of whom 34 were randomized to methylprednisolone, and they demonstrated a reduced risk of their primary endpoint, which was a composite of death, ICU admission, or the requirement for non-invasive ventilation. Since then, we have the recovery trial, which I would say is probably the highest quality trial published during the pandemic. It's a large randomized open label adaptive trial in the UK. And what that means is that it's looked at multiple treatments simultaneously. So it looked at dexamethasone, lopinavir, ritonavir, hydroxychloroquine, azithromycin, convalescent plasma, and tocilizumab. It included hospitalised patients with confirmed or suspected COVID-19. I'm going to speak specifically about the steroid arm, in which patients were randomised to oral or IV dexamethasone at a dose of 6 milligrams daily for up to 10 days, or usual care. The primary outcome for the trial was 28-day mortality. And of all included patients, 6,425 were included in the dexamethasone sub-study, and of whom 2,104 patients received dexamethasone. Death occurred in 428 patients who received dexamethasone, so 23%, and 1,110, or 25.7% of patients in standard care arm. So overall, this translated into a 17% relative reduction for the overall cohort. And looking at patient subgroups, those who required mechanical ventilation or ECMO experienced a 36% relative reduction in death. Those that required NIV or supplemental oxygen experienced an 18% reduction in the relative risk of death. And interestingly, patients who required no respiratory support had a non-significant trend towards higher mortality. So they didn't experience a benefit. In terms of the secondary outcomes, hospital length of stay was significantly reduced in the dexamethasone group, as was the use of mechanical ventilation. Results were similar when analyses were restricted to the 89% of patients who had laboratory confirmed COVID-19. And I think one of the main additional things to take away from this study is that it had very robust methodology. There was allocation concealment, they performed an intention to treat analysis, and had less than 5% of patients lost to follow-up. Some uncertainties remain, however. The baseline mortality was higher than expected, and that means that the absolute mortality benefit in other settings may not be as high. There were also, so the sample size and the timing of the interim analysis weren't set a priori, which increases the risk of type 1 error. and they didn't report adverse effects, including secondary infections, which is clearly an important endpoint for a study of this nature. Data on the efficacy of other glucocorticoids are limited to much smaller trials, several of which have been stopped early based on the results of recovery. For hydrocortisone, there's been a meta-analysis that included 3 trials which evaluated hydrocortisone and found a significant trend towards reduced 28-day mortality compared to standard care, and certainly, a non-significant trend. And certainly hydrocortisone is something that we use quite regularly in the intensive care outside of COVID for shocked patients. In terms of methylprednisolone, there was a randomized trial from Brazil that included 393 patients with either suspected or confirmed severe COVID-19, and they found no difference in 28-day mortality compared to placebo. It's not clear whether the difference in findings between different glucocorticoids is due to the agents themselves, to the dosing, or to other differences. 2 meta-analyses of the use of corticosteroids in patients with COVID-19 have been performed. The first, published in JAMA, was a meta-analysis of 7 trials with a primary outcome of 28-day mortality, and it found a 34% reduction in 28-day mortality with glucocorticoids compared to either standard care or placebo. And both of these meta-analyses have been heavily influenced by the recovery study in terms of the data contribution. There's also been a network meta-analysis of 23 randomized trials that found that glucocorticoids reduced mortality, mechanical ventilation, and the duration of hospitalization compared to standard care. Talking now about remdesivir. So this is a novel nucleotide analog with in vitro activity against the virus. Importantly, it's administered by intravenous infusion for 10 days and costs about $5,000 per course, which will clearly have significant implications for countries with a very high burden of infection and also countries, also developing countries. The first evidence for, or the first significant evidence for remdesivir came from the ACT-1 study, which demonstrated a significant benefit in the time to recovery of symptoms, but no significant difference in survival at 29 days. This trial led to authorization of remdesivir in the UK, EU, US and Australia. And I've listed the Australian government criteria for use of remdesivir on the right. Its main toxicity is liver, and that's why there's a criteria for relatively normal liver function. A subsequent meta-analysis of 4 trials, which included 7,000 patients, confirmed that remdesivir doesn't reduce mortality or the need for mechanical ventilation compared to standard care. The initial Australian recommendation was that remdesivir could be used in patients with severe COVID-19, but these recommendations may change in light of the WHO-sponsored Solidarity trial, which is currently unpublished in a peer-reviewed format. It is available online, and I've included the link for the unpublished data at the bottom of the slide. In total, 11,266 hospitalised patients with COVID-19 were included in Solidarity, and they were randomised to, or the trial tested four different agents, so hydroxychloroquine, remdesivir, lopinavir, ritonavir, and interferon beta-1a. They found, in terms of the remdesivir comparison, they found no difference in 28-day mortality between the 2,750 patients randomised to remdesivir and the 2,708 patients who received standard care. These interim data are awaiting peer review and are expected, the publication is expected to be finalised shortly. But that didn't stop the WHO coming up with a statement that their conclusive findings will suffice to refute early hopes in the 4 drugs studied, which I think no one is significantly surprised by. Talking now about tocilizumab and other IL-6 inhibitors. So as we're aware, the inflammatory process of COVID-19 is extremely significant, especially in critically ill patients. And there are several biologic agents that target the IL-6 pathway that have been evaluated in randomized trials, albeit in small trials. The results of these trials have largely been confined to press releases and don't indicate a mortality benefit over a standard clinical approach. One double-blind randomized trial of 243 patients with severe COVID-19 who weren't intubated found no difference in the rate of intubation or death after a single tocilizumab dose compared to placebo. Another open-label randomized study of 131 patients who were hospitalized but not ventilated found that tocilizumab did not reduce 28-day mortality compared to usual care, even though it did reduce progression to non-invasive or invasive ventilation. Tocilizumab was one of the agents in the recovery study, and the tocilizumab arm of recovery continues. Convalescent plasma received a lot of press, especially in the US. So this is plasma that's obtained from individuals who've recovered from COVID-19. And the theory is that it's believed to provide passive antibody-based immunity. It is possible that convalescent plasma provides a clinical benefit if it contains a high enough level of neutralizing antibodies and it's given early enough in the course. It could also have a role in individuals with defects in antibody production, including those on anti-CD20 therapies like rituximab. In a randomized controlled trial from China, 103 patients with severe COVID-19 were randomly assigned to receive convalescent plasma or standard care. And in this trial, convalescent plasma improved the rate of nasopharyngeal viral RNA clearance at 72 hours, but there was no difference in clinical status at 28 days. Despite this, the FDA did grant emergency use of convalescent plasma for hospitalized patients with COVID-19, but there are international trials which are still ongoing, and there is a convalescent plasma arm of recovery, which is still recruiting. The current Australian recommendations for convalescent plasma are that it shouldn't be used for the treatment of COVID-19 outside of randomized trials. Talking now about hydroxychloroquine. So this agent definitely received a huge amount of press early on in the pandemic, which resulted in an absolute flurry of people trying to obtain it without any real indication. So in vitro, hydroxychloroquine was shown to inhibit the virus, and obviously in vivo it's got immunomodulatory effects, and that's why we use it in many rheumatological conditions such as lupus. Despite early optimism, data from controlled, and the early optimism really came from case series and uncontrolled studies. Data from controlled studies have been largely disappointing. There was a randomized control trial of 479 patients with COVID-19, which found that hydroxychloroquine did not improve 14-day clinical status or 28-day mortality compared to placebo. And a preprint of the recovery trial, which had a hydroxychloroquine arm, found that hydroxychloroquine did not reduce 28-day mortality, but it did actually increase hospital length of stay and the risk of progressing to mechanical ventilation or death. It also has significant potential for toxicity. One trial compared 2 doses of hydroxychloroquine, and this trial was stopped early because of high mortality rate in the high dose group. And toxicity was found to be especially high when it was used in combination with azithromycin, especially in the beginning of the pandemic when that combination overseas was very common. In light of this new evidence, the US has revoked the approval for the emergency use of hydroxychloroquine in patients with severe COVID-19 because of this lack of benefit and the reported potential risks. And similarly, the current Australian recommendation is that hydroxychloroquine should not be used for the treatment of COVID-19. There are also many other agents under review in small and medium randomized control trials. So these include interferon beta, lopinavir ritonavir, monoclonal antibodies, favipiravir, I think that's roughly how it's said, which has been used for influenza in some Southeast Asian countries. And then there's also Janus kinase inhibitor, which we have experience with in rheumatoid arthritis that has immunomodulatory effects and can interfere with viral cell entry. Patients should only receive these agents as part of a clinical trial. And there's certainly a very comprehensive repository of active trials, both through clinicaltrials.gov, our standard way to register trials, but also covidtrials.org. I'm going to speak briefly about vaccines because that's one of the real hot topics over the last 4 to 6 weeks, with some promising early results which have not been peer reviewed or published yet. So vaccines to prevent SARS-CoV-2 infections are considered the most promising approach for controlling this pandemic. Several vaccine candidates have demonstrated immunogenicity without major safety concerns in early human trials. And in total, over 40 candidate vaccines are already in human trials, and over 150 are in preclinical trials. The reason that we've been so successful with developing vaccines so early is that vaccine development for SARS and MERS, which are also coronaviruses, really paved the way for the rapid development of vaccines for SARS-CoV-2. Preclinical studies were already completed for many of the vaccines, and 2 had already been evaluated in small human trials. The major antigenic target of the vaccines is the large surface spike protein, and slightly concerningly, animal studies of vaccines for SARS and MERS have raised concerns for enhanced disease with vaccination through viral mutation, although this hasn't been demonstrated in human studies. To mention briefly the 3 most advanced vaccines currently being investigated, there are 2 mRNA vaccines, which are by Moderna and Pfizer. Yes, and they've been reported in press releases that their large placebo-controlled trials have up to 95% efficacy in preventing laboratory-confirmed symptomatic COVID-19. Interestingly, RNA vaccines represent an entirely new vaccine approach. And since the technology is new, the ability to produce large quantities of RNA vaccines has not been previously tested. So there's a lot of unknowns. And that will have significant implications for people in developing countries in terms of getting access. Importantly, they must also be maintained at very low temperatures, and that will have significant implications for transport and delivery of vaccines, again, especially to developing countries. The 3rd vaccine is an adenovirus vector vaccine, and that's the Oxford vaccine by AstraZeneca. And this has been reported to have 70% efficacy, but this figure does vary up to about 90 to 95% based on dosing regimens. And we really need full trial reports so that we can critically assess the efficacy and the safety of these vaccines. So in summary, 1 year into the COVID-19 pandemic, the optimal approach to its treatment still remains uncertain. Trial data suggest a benefit with dexamethasone in patients who are receiving oxygen or ventilation. And the benefits include reduced mortality, reduced hospital length of stay, and reduced mechanical ventilation. Remdesivir probably reduces symptoms but doesn't reduce mortality. Hydroxychloroquine is not effective and may be harmful. Many other agents are under active investigation, and the availability of peer-reviewed results of vaccination trials and also the secondary analyses of the recovery study are eagerly awaited. Thank you.
Thank you so much for that, Emily. I'll invite the panelists to all turn on their videos. Thank you so much again, Em, Jane, and Lucy, for your very insightful presentations that I'm sure the audience would agree was very enlightening. We're going to go to the Q&A, and I'm very cognizant of time restraints. So what I'll do is start off with a question from Simon Jenkins. And he asks, with all of this going on for the last few months, what workload did you have from routine work and how it's impacted really? So for example, elective or emergency surgery or medical patient scopes, administrative tasks, etc. Perhaps we'll start with Lucy.
Sure, thanks for the question. Yeah, I think that we really did notice a change in case which really just evolved from at various phases of the pandemic. Key differences for us at the Austin was the change in our, we clearly had a decreased number of post-operative surgical admissions, and in particular for quite a long period, a lot of the cardiac surgery patients, which forms a substantial component of our usual workload on weekdays, was that work was undertaken by the Austin Cardiac Surgical Team, but at the Warringal Private Hospital. We also noted that at periods there was change in the transplant workload, and I think another I guess personal observation, which I don't have the data to hand, but I'd be interested in, is we certainly seem to see an increase in the number of patients who were in ICU as a result of self-harm, either suicide attempts or intentional overdoses. And I think that's of interest, because I think potentially that speaks to the other social impacts of the pandemic. I think Jane can probably speak more to the impact on organ donation and then also transplantation.
Yeah, thank you, Lucy. I think before I talk about transplantation, I think the other thing I noticed was we had a lot of delayed presentations. So it felt like we had a lot of sicker, complex patients who ended up in ICU for what I would deem a longer period of time, because there really was a delayed presentation, and it was really quite challenging at times, especially because you were also dealing with an environment that was different to normal. In terms of family visitation, all of your communication was done more virtually. And I truly felt that the last couple of months, from a workload, and I'm not talking the COVID pods, because they were complex and challenging in a different way, because we would have what we deemed SCOVID, where they were really, really unwell. They'd just arrived in hospital. You were trying to do everything in full PPE. You were trying to communicate through face mask, N95, gowns, trying to have a phone call while keeping everything safe and putting in lines. That was challenging. But otherwise, the COVID patients kind of were, I hate to say set and forget, but in a way they were a little bit that way, because they were ventilated. They were fairly straightforward. They followed a fairly routine pathway. They weren't particularly challenging compared to the rest of the pods that we had, that we were very, very busy. We were trying to manage basically 3 pods into 2, essentially, with our COVID that was in the third one. And the patients were delayed. In terms of transplantation and donation, which donation comes first, clearly, the donation, really, we noticed a decrease in consent rate, which is multifactorial, and Donate Life, and I'm sure OTA is looking into that, the Organ Tissue Authority for the country. But we also noticed that a lot of the transplant teams actually shut down their services for a while, both during the first wave and the second wave. And so when we did have transplantation, the patients were the very highly complex, higher acuity patients who needed to be transplanted urgently, which again provided a different patient population to your outpatient routine. Let's say liver transplantation, who would come in, get extubated within 4 to 8 hours, and then go to the ward the following day. So there were absolute changes, even from an intensive care unit standpoint, which I think Lucy, Emily, and I can speak to, as well as Joe Chow.
Thank you for that. Emily, I'll direct the next question at you. This is from an alien. Is there any rationale about some of the other series of unfortunate events and suggestions, really, such as bleach and methanol, and with resultant mortality, sometimes in mass numbers? Can you give us your opinion on that, please?
Yes. So the evidence is that we know that they'll work, but they'll also kill the host, which is the person. So, we know that hand hygiene and sterility in the clinical environment have been critical to minimising the number of healthcare worker and healthcare associated COVID-19 infections. I'm sure that carries across into infection, but obviously those treatments are far too toxic to ever be able to be used in a clinical setting, which is not understood by some national leaders.
Thank you for that. Perhaps we'll go to the last question that all three of you are welcome to answer. It's an interesting one. It's would we have ever coped with a Euro-style outbreak? And I'll add to this as well, and feel free to chip in how you think like Austin Health might be different from, say, another hospital, or how we might be different from perhaps another country, and therefore would we have coped? We'll start with Lucy, perhaps. Yes.
Thank you. I think it's a tremendous question, and I think it's probably one that we all ask ourselves throughout this session. And you know, I guess we never know the counterfactual, but I think even my experience of working through the very small initial Melbourne peak and then the subsequent peak, what was clear to me was that the initial peak felt busier because there was so much uncertainty and so much of the planning had to occur urgently. And, you know, I think as Jane, Dr. Lewis and, you know, Dr. Ellard have described, just sort of the volume of work that had to be compressed into in order to establish safe processes was tremendous. And so I think really where we benefited was that the volume of cases we had during that first wave was relatively low, because absolutely, I think it has to be acknowledged, you know, there were things we were getting wrong in March and April, or not even wrong, but things that could be done better. And what we've had here in Melbourne is, you know, we're unfortunate, I guess, in that we've had this second wave, but fortunate in that it happened several months after when we had established processes. And even looking back, things like, simple things like our behaviour around staff communications and staff meetings. You know, early on, I don't think ICU were alone in that we were still having face-to-face meetings in March. And in fact, during the course of the year, we now are very comfortable with the idea that it is safe and appropriate for us to meet via teleconference. And you can easily imagine how we could have have furloughed or quarantined very quickly large portions of our staff if we'd had that higher caseload early on. So I think it is the humble thing to acknowledge that we have been lucky in Australia to have had the opportunity to learn from, everywhere else in the world that is experiencing this pandemic. We've seen that the deluge of research that's occurring, and also have the opportunity to critically evaluate our own practices and build them over time before we've been faced with those higher caseload. I tend to think that any system put under sufficient strain, you know, will get to a point where it is not coping. And by that I mean that we would, you know, of course it is possible that we would be in a situation where we could not deliver the high standard of care that we expect. I think up till now we've been able to deliver care that is familiar and is of a familiarly high standard. Yeah.
I'd like to really echo what Lucy said. I think it's your definition of coping and how we do that. We are incredibly lucky that we weren't put under the numbers that we were expecting to get with the initial modelling. And I think that was, part of the March, April, I want to call it almost panic, where we were trying to actually process how we were going to do this. We had so many amazing volunteers, people offering to help. We were trying to figure out how we would actually manage an ICU with over 100 beds with additional support staff. And I think that's where the protocols versus individualized care, the ventilator splitting versus having enough ventilators, it was all of the background work that was actually massive. And I know that it wasn't just us, it was every hospital in Melbourne, every hospital in Australia, trying to figure out how to do this well independently, talking amongst colleagues, trying to figure out how best to do it. I think we were not expecting the second wave that we got, but we kind of were very thankful that we had processes and protocols and everything in place. So, and we were starting to get equipment at that point in time as well. So I think it really depends upon when you defined the crisis occurring. If it had happened in March and April, which was initially what we expected with the modelling, I think the moral distress and anxiety amongst everyone was much higher. Definitely through the second wave, absolutely as well. But I think we kind of felt like we had more established processes, policies. We had people that we could turn to. We'd already started the ball rolling initially on how to do it. And I think my biggest concern, and even just observing overseas, is the moral distress of everyone, the PTSD that's going to come. You know, we can sit here and have a really fascinating conversation about this, but we have been so privileged and so lucky in our country and in Melbourne that we didn't have to deal with what they dealt with and what they're dealing with now. So I guess that's my perspective.
Thank you, Jane. That's all the questions for this session. Thank you so much, Dr. C, Dr. Louise, and Dr. Modra. It's been really insightful, and like I echo what Jane said, I'm very grateful to be here. Shiva, it's back to you. Thank you.
No, thank you very much. We will have about a couple of minutes break, maybe make it 4.5 minute break, and then we'll come back. And I do apologize for the running over time, but I think every talk was quite valuable and we could not cut them short. Thank you. So we've got to the last session. Dr. Ainsley Lorych is our chair for this session, and so far I've been just here. My ears are glued to the screen, so Ainsley, go for it.
Thanks, Shiva. Hi, my name's Ainsley, one of the advanced trainees on the Northwestern Anaesthesia Training Scheme, and the Austin Hospital is my home hospital. I'd just really like to thank the previous speakers for their fabulous presentations. They've been really informative so far and generated some excellent discussions, so thank you. For our final discussion, we have 5 wonderful speakers from the Austin's Anaesthesia Department, and these speakers will be discussing a variety of different topics related to COVID-19, including wellbeing, obstetrics, personal protective equipment teaching, simulation, and N95 fit testing. And just to reiterate, if you have any questions related to these discussions, please use the Q&A section on your screen, and we'll endeavour to get to the questions as best we can. All right, so introducing our first speaker, we have Dr. Vanessa Andean, who is a visiting anaesthesia consultant at the Austin Hospital. Vanessa works in a mixture of public and private anaesthesia in Melbourne and has a special interest in teaching and wellbeing. During the COVID lockdown, Vanessa rekindled her love of the books of Jane Austen. Welcome, Vanessa.
Ainsley, thank you very much. And it's a great pleasure to speak to all of you about some of the issues around the wellbeing of our healthcare workers. Lucy and Jane have already touched on some of the problems affecting the welfare of people working in ICU. My perspective will be slightly more anaesthesia based. We all know that this is a serious issue, and there will be a lot of work that comes out of this pandemic on the topic, as in so many topics, once we have a little bit more experience of the situation. But I'd like to begin by summarising the wellbeing challenges of the COVID pandemic using 2 words. And those words are chaos and connection. So to my mind, this pandemic has been extremely pro-chaos and very anti-connection. Our experience of these 2 elements has been universal, but it's also been intensely individual. Firstly, by chaos, I mean all of those uncertainties, unforeseeables, upheavals, losses, cancellations, fears, bereavements, irritations, inconveniences, and most of all, the isolation that suddenly invaded our lives in about March of this year. The lack of defined endpoint magnified the problem. How do we sustain any response indefinitely? The possibility of a vaccine and extremely low case numbers around the country have given us the feeling that now perhaps an end is in sight. But there was a time, particularly in Victoria, where it seemed that we were going to be stuck in a hole for a very long time. Secondly, connection. By this, I mean our ease of interaction with and our proximity to the things that are important to us. I'm thinking especially of people, but these things can also include our work and the things that we like doing outside of work. Clearly, the professional and the personal are inextricably linked when we think about connection. So what happened to connection during the chaos of the pandemic? Well, we were all affected by separation from friends and family during lockdown, so a significant reduction in important connections. Many households were homeschooling, so perhaps some had too much connection with some family members. A lot of us had changed working hours, some increased, some decreased, and there was the possibility of financial pressure. Even for those of us who continued going into work as usual, say in the operating theatre, there was significantly reduced casual interaction with colleagues. Tea room and hallway debriefing disappeared almost entirely. At the height of the first and the second waves, there was the fear of getting sick at work and of infecting our families. This was particularly worrying for those who had vulnerable people at home. Plenty of doctors and nurses lived separately from their families for a time in an effort to keep them safe. A lot of our time and energy went into trying to keep ourselves and our possessions clean during the work-home transition. Crowded change rooms became a source of potential infection, as did tea rooms, and a lot of us found ourselves with nowhere to eat our lunch. Many of our usual outlets for stress became unavailable. Exercise, group activities, and a few of us had to make friends with our new COVID kilos. I think amongst all of these new things, PPE is its own special category of chaos, and it illustrates the connection problem very well. Once you're wearing your PPE, you're really anonymous. No one knows who you are, and they can't tell if you're smiling or if you're frowning. No one can hear you properly, and you can't hear anyone. So everyone can end up shouting and sounding angry and stressed, even if they're not. There's poor visibility in a crisis, and even at the best of times, it's bloody uncomfortable. There's the stress of getting your PPE on and off properly, and the time that this takes. There are reduced opportunities to eat and drink and to take breaks. Different hospitals have different guidelines for PPE, and these at one stage were changing week to week or even day to day. This was especially challenging for those of us who work at multiple hospitals. And we'd often start the day by having to say, well, what am I wearing today? Because it was sometimes different to what I was wearing yesterday. So all of this is sounding very gloomy in terms of our well-being during COVID. What do we do about it? So if you follow the model I've outlined to you, the solution lies in trying to reverse the chaos connection dichotomy. And by that, I mean decrease chaos and increase connection. Many of the strategies we employ to tame chaos at our hospital have in fact been discussed in detail today already by other speakers. Things like fit testing of masks, simulation training, the formation of dedicated intubation teams are all examples of how we waged our war on chaos. Standardization of protocols and very clear lines of communication are other ways of reducing chaos. So how about increasing connection? We all started to see simple things like people writing their names across their foreheads or their chests when they were wearing PPE. A buddy system for the correct donning and doffing of PPE improved safety. And it's also just nice to know that someone is looking out for you when you're in the plastic bubble. However, when we started looking at providing formal connection and support, we found that it's tricky. People can feel clunky about reaching out to others or asking for help. Doctors are particularly bad at this. Imposing help and support is often counterproductive, and people frequently have their own support networks. But how can we reinforce them? We were aware that our best routine is often each other. The question is how best to access that resource. In the Austin Anaesthetics Department, we decided to try a peer support buddy program. Our registrars already had consultant mentors, so the challenge was to try and integrate 105 consultants into a new peer support network. We asked that all anaesthetists be involved, and we randomly allocated each anaesthetist to buddies, one person who they would contact and one who they would be contacted by. We asked that they contact their buddy, usually by phone, every couple of weeks, just to touch base and to have a social conversation. And we encouraged that these conversations take place through the first and the second lockdowns in Melbourne. We asked that any serious mental health issues be referred to senior members of the department. There certainly wasn't an expectation that this program would provide any sort of psychological or psychiatric services. In terms of assessing the efficacy of this program, it's hard to monitor the effects of an approach like this one, even with the help of a survey. We're pretty certain that there were no adverse side effects, and we had anecdotal reports of people having useful conversations that they might otherwise not have had. There were also plenty of people who didn't ever get around to making or receiving their phone call and who didn't feel that the program was any use to them at all. What is clear from this experience, and perhaps it's symbolic of the entire pandemic, is that while there have been universal challenges and stressors, each of us has coped in extremely individual ways. It's difficult to provide formal support that will help every individual, but it's still worth making the effort. There's really not much to lose. I'd like to finish here by pointing you towards some of the formal resources that are available to support wellbeing. I'll put them up in the chat afterwards as well. The Black Dog Institute has developed an e-health hub called the Essential Network. Alfred Health has a free mindfulness app called Treat. This Way Up is an online mental health program developed by St Vincent's Hospital in Sydney. And with that, I'd like to thank you all very much for both speaking and participating, listening in this symposium. I'll pass you back to Ainsley.
Thanks, Vanessa. I'd like to introduce our next speaker, Dr. Emily Jenkins. Emily is an Anaesthetic Registrar in the Northwestern Training Scheme. She's got a special interest in obstetrics anaesthesia. She has a RANS-COG diploma in obstetrics and a Bachelor of Medical Science focused on influenza vaccination in pregnancy. And when she's not trapped in Melbourne by a global pandemic, she's passionate about exploring different places and cultures, and to date has travelled to around 89 different countries across 6 different continents. Today, Dr. Jenkins is going to talk about COVID and the obstetrics patient. Welcome, Emily.
Thanks, Ainsley, and thank you so much everyone who's joining us this morning. I'm just going to share my slides. Please let me know if there's any issues with them coming up. So what I'm doing this morning is really giving you a bit of a 101 of COVID in pregnancy, and with a particular thought to the non-obstetric anaesthetist who may need to manage a COVID positive obstetric patient, potentially even at a non-traditionally obstetric hospital. So let's start by taking a look at what we know about COVID in pregnancy. And I think this is largely a good news story. So in previous pandemics like swine flu and MERS, we saw that pregnant women were a particularly high-risk group, that they had a really disproportionate amount of morbidity and mortality. And thankfully, this has largely not been what we've seen during the COVID pandemic. So now that we've got about 12 months worth of data slowly filtering through, we've seen that there is still an increased risk, but it's certainly not what was seen previously. So what I put up there is data from America, from the CDC, and also a large systematic review that was published by the COVID-19 consortium, a British group, which compiled the results of 77 different cohort studies. And what they show is a small increased risk of ICU admission, invasive ventilation, ECMO, and death amongst pregnant women who contract COVID, and also an increased risk of preterm birth and associated complications for the babies involved. But importantly, they have not shown a statistically significant increase in pregnancy loss or fetal malformations, such as what we saw during the recent Zika scare. So let's zoom in a little bit on the Australian experience. And I thank very much Dr. Claire Whitehead from the Royal Women's Hospital, who's the lead on the Coronavirus Health Outcomes in Pregnancy and Newborns Registry, which is following up this cohort of women in Australia. And she's very kindly let me share a little taster, if you like, of their findings so far. And as you can expect, the infection in pregnant women in Australia has very much followed the same sort of pattern as in the general population. So we had that a little sort of bump, if you like, as returned travellers came back to Australia. And then we had a much larger second wave in Victoria, which was really driven by community and workplace transmission. And unfortunately, one of the things we learnt was that healthcare workers were really disproportionately represented amongst pregnant women who caught COVID in that second wave. So whilst numbers have been relatively small overall, and most of the women who've been infected have been infected early in their pregnancy, we've still had about 15% or so of the 80 or so cases positive at the time of delivery, which of course carries really important implications for anaesthetists and other healthcare workers. There was about 15% who required ICU admission, either for respiratory or VTE indications. And the majority of these women, or the largest cohort of these women, were cared for at the Royal Women's Hospital. For those of you who are not familiar with the setup at the Austin, although we're co-located with the Mercy Hospital, which is one of the other major obstetric hospitals in Melbourne, we share ICU facilities with them. We were thankfully sort of quite protected from that second wave amongst pregnant women. So now that we know that pregnant women in Australia are getting COVID and the COVID infection they're getting is potentially more serious than if they hadn't been pregnant, what do we need to do, or what can we do about this? And as I'm sure you can imagine, as we've had these huge waves of data emerging, the guidelines and the recommendations have been a little bit of a shifting goalpost. Thankfully, we've got the National COVID-19 Clinical Evidence Task Force, which is providing what they're calling living guidelines. So they're updating weekly in line with emerging evidence. And of course, then those guidelines or those recommendations filter down to a state and then a more local hospital level. I think the big thing we would notice as healthcare providers, but what also the pregnant women are definitely noticing, is this pivot towards telehealth and doing consultations by phone or by a Zoom type platform. And going hand in hand with that is also a slight change in some of the antenatal schedules, so around ultrasound screening and also things such as blood tests. So an example being, instead of women going to a pathology provider for several hours to have their OGTT for gestational diabetes screening, a low risk woman is just having a single blood test to minimise her risk of being in a healthcare environment where she could contract COVID or vice versa. For a COVID positive woman at the time of delivery, there are recommendations for hand hygiene, mask wearing and social distancing where feasible and possible from the baby. But overall, thankfully, the risk of vertical transmission appears quite small. So there's no change in recommendations for when and how a woman gives birth or whether she chooses to breastfeed or room in with her child. Talking about treatment in pregnancy is a little bit tricky because it's essentially a bit of an evidence-free zone. As I'm sure you can imagine, there's been very limited enrolment of pregnant women in these big trials, which have guided our therapeutic uses, as discussed by Emily in the last session. So what that means is we're really relying on being able to extrapolate data from non-pregnant patients into the pregnant cohort. So in the sort of 2,000 or so trials which have been registered since COVID emerged 12 months ago, only 1% or thereabouts have enrolled any pregnant women, and usually they're very, very small numbers. Like you can see there, the recovery trial, which has really guided a lot of our use of corticosteroids in patients with COVID, enrolled just 6 pregnant women, which is, you know, a tiny sample size, and most of the other trials have had none. So just to recap quickly what Emily was talking about, our guidelines in pregnancy very much mirror general guidelines as discussed by Emily. So dexamethasone is recommended. Remdesivir is a little bit of a grey zone. It's certainly being used in clinical trials, but is not formally recommended beyond that. And there's no evidence to suggest the use of any of the other therapeutics is beneficial in pregnancy. In terms of the non-pharmacological respiratory supports, once again, very closely mirroring the recommendations for non-pregnant patients, although of course there's a few additional logistical considerations. I'm sure you can imagine it'd be pretty challenging to prone a heavily pregnant woman with a gravid uterus. And so there's a very low threshold for considering delivery if it's thought to enhance maternal resuscitation in women who've got quite refractory hypoxemia. What there are a lot of guidelines about is about VTE prophylaxis. As I'm sure you're all aware, pregnancy is already a time of increased risk for VTE, and then COVID is increasing that risk further. We're not really sure, we can't really quantify the severity of that risk or the duration of that risk, but certainly the recommendations are that pregnant women with COVID should be receiving VTE prophylaxis unless there's an alternative contraindication. And in fact, for women with severe disease or who have additional risk factors for VTE, then an increased dose should be considered. So sort of a hybrid, half therapeutic, half prophylactic type dose, for example, enoxaparin 40 BD. The reason I'm flagging that is, of course, if you're asked to come and do an epidural or a spinal on one of these ladies, expect them to be on VTE prophylaxis and to, of course, check the timing of the last dose. That leads us nicely into some of the other anaesthetic considerations. And I've put up there some of the sort of non-pregnancy specific ones when we're talking about GAs or other aerosol generating procedures. But I think Dr. Ellard's already talked about these very nicely, so I might just skip over that. Of course, even though it's very exciting having or anyone with COVID in the operating theatre, we've still got to remember all those really basic obstetric anaesthetic considerations, such as recognising this is a potentially difficult airway with an increased rate of failed intubation. And of course, remembering that wedge to prevent any aortic cable compression. But there are a few things which are a little bit different in the COVID setting for our roles as anaesthetists. We've got to do the basic things like making sure the woman and yourselves are in an appropriate hospital, wearing appropriate PPE, and that you've had appropriate training and simulation. But the two big things really is early epidural and then going hand in hand with that, the avoidance of a general anaesthetic as an aerosol generating procedure. In the very, very early literature about neuraxial techniques in pregnancy, there was a little bit of concern about low platelet counts in pregnant women with COVID, and also about potential hemodynamic instability and other sort of issues with spinals. But that has not been replicated on more subsequent and more sort of methodologically robust publications. And so we think either a spinal or an epidural is equally safe with COVID as without. And of course, the benefits is of the epidural potentially alleviating some of the respiratory exhaustion that may result for a labouring woman with COVID, but more importantly, reducing the risk of having to have an emergency caesarean under general anaesthetic. When we're thinking about the avoidance of GAs, a suggestion that has been come across from a lot of the authors in the literature is consideration of a CSE as your first line choice of neuraxial technique in a non-emergency caesarean, just so we can make that risk of conversion to GA really as small as possible. And the other thing I just flag as the point for consideration is our COVID pregnant antenatal patient will have a degree of respiratory embarrassment, which is only going to get worse when she's lying supine for the caesarean. And so to have a little bit of a plan in place for how her respiratory support should be managed during the caesarean. And what we've seen in the literature is, not surprisingly, very high rates of caesarean sections in COVID positive patients, anything from say 40 up to about 100% in some of the studies. And for your reference, our baseline rates is around about a third of deliveries are by caesarean. So let's put this all together. I think there's a couple of really key lessons that have been learned from the Melbourne experience. The first is that telehealth is challenging. It's obviously not the pregnancy and birth experience that women envisioned that they're getting this year, and things like trying to examine an airway or a woman's back by phone is obviously incredibly challenging, but we're all learning, we're all adapting, and I'm sure we'll continue to do so. Unfortunately, we've also learnt that our healthcare workers who are pregnant are a particularly vulnerable group for workplace transmissions, and managers have to be really cognizant of how they can manage and mitigate that risk. I don't think we can overstate the importance of training and simulation to make sure that all members of the team involved in the care of these women have had a chance to sort of work through any little glitches or potential issues before they're doing it in real life, so to speak. And that's particularly true in non-obstetric or traditionally non-obstetric hospitals who may need to care for women during their pregnancy with COVID and potentially be doing caesareans and other procedures they're not used to doing. Clear communication around a woman's COVID status or risk is incredibly important to protect healthcare workers from inadvertent exposures in the workplace. One way that that's been done in several of the hospitals in Melbourne is by changing the way overhead emergency pages have been worded. So, for example, at the women's, their calling codes or MET calls has PPE to denote the COVID or SCOVID status of the woman. At the Mercy, the N95 has been added to the end. So, for example, like Met Call 95, once again to denote the need for additional PPE to be worn by people attending the emergency. And other hospitals have got rid of code greens for COVID positive women and have made them all Cat 1s, once again to just protect staff from exposure during these quite time pressured and emergency situations. Timing of delivery is a really challenging one. It's subject to a lot of ongoing discussion and debate by the experts, but I think a very reasonable approach is to aim for in-hours delivery of COVID positive women so that senior obstetric and anaesthetic teams are there to manage the lady. What you're really trying to avoid, of course, is having an emergency case done after hours by perhaps inexperienced or more junior trainees, or an emergency which progresses to the point of requiring a GA because of it being such a time critical scenario. Of course, all of these things can help be minimised by the use of early epidurals so that if there is a subsequent need for an emergency caesarean, that epidural is already on board. And then the final point is that we will see an increased caesarean rate, and so to make sure that there's appropriate planning around beds and overall increased average lengths of stay as a result. Thank you very much. I'll pass back to you, Ainsley.
Thank you, Emily. Great talk. Our next speaker is Dr. Radha Vivekananthan, who is a staff anaesthetist at the Austin Hospital, and she has a special interest in mentoring, quality and safety. Outside of medicine, Radha enjoys learning Italian, and this is much to the mirth of her Italian patients. Radha is going to be talking about personal protective equipment teaching during the time of COVID. Welcome, Radha. Radha, you might need to unmute yourself.
Just sharing my slides now. Can you confirm that you can see them?
Radha, I might get you to start again. I've just had to unmute you. So
can you just confirm that you can see my slides?
Not yet.
Sharing my slides. No.
No.
You may want to turn on your camera as well.
Okay. Let me just see. Sorry about that. Let me see. Start video. Share slide. How's that? Shared it all? No?
Not yet.
Oh, okay.
Eva, do you have some assistance for Radha?
It's the same as we did yesterday. Should
yes.
work nicely, yeah.
It did work yesterday. It's not working today. I might just have to talk without that. I'm afraid. Nothing at all there.
No, unfortunately, Radha.
Okay. So I might just have to talk without the video because I don't want to really waste people's time.
Do you want to send it to me? Do you want to send it to me and I can share it? Email me, or it doesn't work?
look, I think in the interest of time, I'll just talk if that's okay. So sorry about that, everyone. For some reason it's not working. We did trial it yesterday. So I'll be just talking about PPE teaching in the time of COVID, and starting with a quote: "If you need to be right before you move, you will never win." A quote by Michael J. Ryan, who's Executive Director of WHO Health Emergencies Program, and that's really reflective of the fact at the beginning of the crisis there wasn't a lot of evidence, and so we just had to work quickly, a little bit like Jacinda Ardern saying go hard, go early. What we did have early on is that the Chinese Centre of Disease Control and Prevention noted that 4% of the reported cases were healthcare workers, of whom 15% had severe disease. Part of what we did in terms of PPE teaching, as alluded by Dr. Ellard earlier today, was part of an overall department response. We'd submitted a paper to an international journal for peer review on anaesthetic preparedness in response to the COVID-19 pandemic, a single centre experience and lessons learned. So what did we achieve? 178 anaesthesia staff taught in person, donning and doffing with N95 mask fit check. It's 93% of staff within the first 5 weeks around the time of the first wave. There's also a stockpile of P3 respirators for those unable to fit N95s, and PEPPers, as alluded by Dr. Ellard, for the COVID intubation team. How did we achieve this? Through stratification from Alpha, Bravo, Tango, and Charlie subsections of our department with varying risks of COVID exposure. This involved dedicated sessions. We were rostered on to teach, and it was mandated. And this all sort of really reflects the fact that the health of our healthcare workers was of great importance. And already alluded to earlier today was the fact that at the Austin, we had 49 cases, potentially only 10 of those involving staff exposed to the infection at work. How do we make this effective? By being flexible, adaptable, infographics, which are on my slides, but I've already been alluded to by Dr. Ellard, and those infographics were really helpful in that they were clear, they were visual, they were able to be, they were on a department app that we had at the time and could be easily updated. And a lot of that work was done by Lockie Miles, one of our colleagues, who put in a lot of work on those infographics. How else do we make the PPE teaching effective? It was through small groups with 1 trainer to 5 people at the very most. In terms of tips and tricks, we suggest that any teaching be systematic and not ad hoc. When we first started teaching, it involved just a piece of paper on the tea room door where people would just volunteer or put their names down, but that was not particularly efficient. So having small groups, practical teaching sessions where you actually had someone donning and doffing, and a spotter in particular for the doffing period, where it's obviously the area of heightened risk. That the communication was visual and easy to understand, and knowing that when you do start teaching that people know, as Vanessa's already alluded to, that it would change almost daily at the height of the pandemic. In terms of reflections myself, there was a lot of anxiety associated with the changes, particularly when we were teaching and just in general. And anxiety associated with one's own mortality and potentially bringing COVID home to loved ones. As a member of Bravo, the Bravo team who was seconded to intensive care, if that should ever happen in your stage in terms of working collaboratively or being sent to another department, certainly I enjoyed it. I'd volunteer again. It was a time of stress, but it was really good to work collaboratively with other departments. We got great clinical support, and I have greater empathy for those ED and ICU trainees on rotation to anaesthesia. What really was highlighted to me was the sadness of people dying alone. At the time when I was there, we had a policy that no family was allowed to visit unless the patient was dying, and we had to make the call, talk to the director and allow the patient's family member to come, which there was one case where that happened, and at least the woman involved, her husband was there for her final hours, which was really quite confronting. And coming back to anaesthetics, I'm pretty glad that I only look after one patient at a time after finding an ICU sort of 14 or more patients at a time is just normal. What was also connected to, as Vanessa alluded to, in terms of the stress levels, what we also brought out was debrief sessions. So it's been a time of great stress, particularly for our trainees, given issues with exams and distorted training time. So we offered debrief sessions to consultants, trainees and HMOs. These were organised via small group sessions with a clinical psychologist, and based on surveys of those trainees, we've had excellent feedback. These are going to be ongoing post-COVID. I'd like to acknowledge this PPE teaching was done as a part of a group and part of a team. So Dr. Tim McCarr and Dr. Doug Hacking were the two other staff anaesthetists involved in teaching, and also our anaesthetic nurse educators, Teresa Hewitt, Madeline Cronin, and Ainam Simon Hickleston. That's all I have to say. Thank you very much. And I'm sorry about the problem with the slides. And I'll get back to you, Ainsley.
No worries at all, Radha. Thank you so much for that talk, and never mind about the slides. Our next speaker is Dr. Stephanie Chen. Stephanie is a staff anaesthetist at the Austin. She did her anaesthetic training primarily through the Austin Hospital, and then went on to do a regional fellowship at St Michael's Hospital in Toronto. Having developed an interest in simulation and its use in medical education, she has since completed simulation instructor training in Boston and further studies in medical education. She is part of both the simulation and regional anaesthesia special interest groups within the Austin Hospital Anaesthesia Department. And when Stephanie is not at work, she can usually be found with her dog Coco, her miniature schnauzer, at the gym or eating. Welcome, Stephanie. Stephanie is going to talk to us today about COVID simulation.
Great. Can you hear me, Ainsley, or others?
Perfect. Great. I can see your slides. So
fantastic. Great. So I am speaking on simulation today and our response to COVID using simulation. So obviously we're preparing for the worst. And as you've heard today, the main thing with us was looking at the rest of the world and watching them have thousands of cases daily and their hospitals getting overwhelmed. We were very concerned early on about staff safety and how to reduce potential healthcare worker infections. And we could see from the start, logistically, it all sort of main things were the fact that it would involve multiple departments within the hospital, and even within the operating theatre within Austin and the repat, it will also involve multiple craft groups. And the facets that we'd have to address are multiple. So PPE, as we've talked about, patient flow systems, interdepartmental transfers, and for many more. And the main thing, obviously, was things were very time critical, so we had to get a move on. Louise has already talked a lot about what we did as a department. So this is mainly what affected the simulation team. And that was mainly the development of the COVID intubation team. So Team Alpha, which consisted of consultant anaesthetists and anaesthetic nurses, looking at patient flow. So we risk stratified people in terms of their COVID risk, the procedural risk in terms of the types of surgical operations they were having, and also looking at infection control during patient flow. So things like locking down corridors or cleaning lifts. We also then looked at how we would respond in emergencies with COVID patients. So code blues, time critical endovascular clot retrievals in radiology, and potential time critical surgeries like ruptured AAAs. And part of that response also looked at things that involve biomedical engineering. So creation of negative pressure operating theatres, and formation of safe anti-rooms. So giving you an idea about the simulation team's response, pre-COVID, we usually ran about 42 sim sessions a year, which accounted for about 47 hours. And this was mainly addressing training with our anaesthetic registrars or potential crisis simulation in a theatre multidisciplinary sort of setting. But in a period of just under a month from March to April, we actually ran 133 sim sessions totaling about 135 hours. So that's triple our usual annual output in just a month. Our main focus initially was training up the COVID intubation team alpha, but then we also then expanded to look at the operating theatres in both the Austin and the surgery centre, and also expanded to other units like ICU and ED. We moved to wards, so both COVID and general wards, and then also to off-site, or I guess off-site places like radiology and the cath lab up in cardiology. Here's a sort of idea of the people that we managed to capture. Very early on, we managed to capture all our staff, 100% of our staff anaesthetists and almost 70% of our VMO anaesthetists, and close to 90% of our trainees. Captured 100% of our anaesthetic nurses and about 80% of our peri-op nurses, and also looked at other people in theatre like technicians and PSAs as well. And then we also expanded out to ICU and various other craft groups. So 342 staff members across 18 specialties in that month period. The purpose of our simulations was to rapidly familiarize people with, and also to be able to practice various things. So the main thing was getting people familiar with the different types and forms of PPE, and then running through safe donning and doffing procedure, which Radha and the PPE team were primarily responsible for. We then had to train people in terms of the different protocols that we have. So there's a little infographic there showing that we had different things stratified based on both patient and surgical risk factors, and that would determine the type of PPE, as well as things like room resting time and lockdowns. We had to practice COVID intubation team activation sequences, the actual intubation sequence, and keeping our healthcare workers safe as they could be, looking at operating theatre flow sequences, and then through that, establishing people in individual craft groups to understand their specific roles and responsibilities. So people like theatre techs knowing when they should be in the room or out of the room, or scrub nurses knowing when they should once again be in or out of the room and what PPE they need to wear. And then once again, as I talked about before, looking at what the safe sequence is for emergency responses in COVID patients. Part of all of that also involved being able to create and test protocols both at the Austin and at the surgery centre, involving multiple departments, that let us identify and resolve system issues, and also optimize new processes for us to be able to establish, I guess, the protocols that ended up becoming what we treated as day-to-day sort of procedures. Here's a list of the different scenarios that we ran. So you can see that we started out with our focus being on COVID intubation, and then transferring from different locations to ICU to perform a COVID intubation. We moved from there to look at complications post a COVID intubation that might need further involvement. So things like cannot intubate, cannot ventilate, or deterioration. And then in the operating theatre, we looked at the different risk stratification and the patient flow for that. And then we moved on to look at cardiac arrest on the ward and time critical procedures like cath lab STEMIs and endovascular clot retrievals in radiology. Here's a couple of photos of some of our simulations. So this is the anaesthetic team donning their PAPR, practicing transfer from ED to ICU, practicing a COVID intubation in ED, and then a COVID intubation in ICU, practicing a transfer of a COVID patient from the ward down to ICU, and then doing a radiological clot retrieval. So you can see that we reached a rather large variety of locations and scenarios in our time. In terms of looking at how we went, we actually did an audit using a survey during that period of March to April, looking at the 389 staff that we trained, of which we got about 168 respondents. We had a nice spread of people between nurses, doctors, PSAs, and other participants. And greater than 90% of respondents reported that the simulation either strongly contributed or contributed to their perceived COVID-19 preparedness. And for people that actually were involved with a actual COVID or SCOVID patient in real life, they did report 78% thought that it was very similar, or 20-something% was very similar, and 56% somewhat similar to real life. So about 78% in total reported that simulation did help them or reflected their experience. The major themes we identified that people thought simulation provided a safe opportunity to practice in a safe environment, allowed them the ability to ask questions and understand the processes, helped us identify potential improvements in workflow, and it also really empowered the healthcare workers that were involved. In terms of where we've gone on from there, since our initial program, it's expanded that the operating theatre led by the nurses decided to run a multidisciplinary simulation within theatre to look at preparedness for a COVID patient. And this was a daily session that ran for about 4 weeks. And the primary focus there was looking at the whole of theatre. So not just the sort of anaesthetic and intubation part of things, but looking at peri-op nursing, recovery, PSAs and transfers. And then other than that, as our registrars in anaesthetics rotated to different hospitals, we had a new batch come in and we were able to induce all of them into safe COVID airway management. So we addressed both anticipated difficult airway and code blue in that session. And then we've also made sure that all anaesthetic consultants that are on the general call roster that might be involved in potential COVID airways have regular COVID airway simulations for preparedness. What have we learned in this whole process? Many things. Mainly that the early use of multidisciplinary in situ sim allows rapid identification of potential systems, logistical and communication issues. And then using that, it really allows you to address guidelines and protocols that you're creating. And so ideally, all your guidelines and protocols should run through a multidisciplinary in situ sim to predict what sort of real life implementation issues might arise. Using multidisciplinary sim, it's really much easier to rapidly disseminate information to participants, and it really lets, from what we've heard back from people, lets them feel more prepared in a short period of time. And having regular simulations also encourages better communication and smoother teamwork. In terms of what we achieved for the department, to date, we've probably now performed over 230 hours of simulation sessions. We've managed to have a publication in a simulation journal of a novel technique that we use called Talk Through, Walk Through when we were starting our initial response to COVID. We've collaborated with the University of Melbourne to help in a statewide COVID nursing training called Critical Care Nursing Essentials and help produce some videos for them. As I talked about, we did that audit of our participants, which was presented at Austin Research Fest. And through everything that we've done, as many people have previously mentioned today, we really strengthened that interdepartmental relationship. And we're really using that from the simulation department to have a future focus on how we can integrate translational simulation into our future. And I think there really has been a significant increase in the interest and appreciation for the role of simulation in not just a crisis, but also potentially in sort of how we can learn to do things in an everyday way. And thankfully, there were no COVID outbreaks, as far as I'm aware, linked to STEM department activities. So thank you very much. If there's any questions or comments, I'm always happy to receive emails as well. So that's my email address down there.
Wonderful. Thank you very much, Stephanie. Our final speaker for this morning is Dr. Caitlin Lowe, who is a visiting anaesthetic consultant at Austin Health, Eastern Health and Dandenong Hospital. Caitlin completed a Masters of Clinical Research Methods in 2018 and is currently completing another Masters in Perioperative Medicine. As part of this Masters course, she undertook an N95 fit testing study, and we'll be talking about this today. Outside of medicine, Caitlin's busy raising 3 girls. She loves reading, crafting, and can't wait to travel again, like all of us. All right, welcome Caitlin.
Thank you. Thank you, Ainsley, for the introduction. So fit testing. Fit testing is one of those things that have gained a lot of media attention. But I would like to let you know that as in February this year, like many Victorian doctors, I had never even heard of such a thing as fit testing. This is despite the fact that, I've been using N95 respirators on and off for the last 15 years. But when COVID hit, my sister, who is an anaesthetist in Hong Kong, asked me, have you been fit tested? And so when I started looking into the fit testing business, I was really surprised to find out that we weren't compliant with such a crucial aspect of workplace safety. So one thing led to another, and I learned how to do qualitative fit testing and then quantitative fit testing. I got my certificate as well. And then the fit testing project that I did at the Austin. So just to give you a little bit of a background, this is the respirator family. a respirator basically is just, any respiratory device that's used to reduce the risk of breathing in environmental contaminants. And so this can be divided broadly into air purifying respirators and supply.
Can I get you to stop for a second and then turn off your share screen and then turn it back on again?
Oh, okay. Turn off sharing screen and share again.
Share it back up again and see how we go with that.
Oh, okay.
I think we did the wrong order. That's what happened.
Some of the participants haven't been able to see your screen, Caitlin.
Oh, okay. Let's see. What about now?
No, it's not working. Let me see whether I can fix it.
I sent it to you as well, for what it's worth.
Yeah, okay. So I'll see whether I'm just trying to think what's the best way to do it. Whoever cannot see it, let me know and I'll try to fix it. One by one. I can do it one by one.
Oh. What about now? Can people see it now?
No.
All right, so yeah, so obviously some people finish.
It looks like it might have been resolved, Shiva.
Oh, it's on the presenter view. So it's this, share, and
we can read all your notes, Kate.
Okay, so what about this? Am I sharing the right thing now? Or is it on the little presenting mode still?
I think it looks great, Caitlin.
It's black, and I don't know why it has happened, and I could just couple up. Okay, see how we go.
All right, so this is good. Okay, so this is the respirator family. Respirators can be divided into air purifying respirators or supplied air respirators. So the supplied air respirators are ones where you're basically piping in clean air to the person, either through a compressed gas cylinder or from a different environment. And the air purifying respirators are what we normally use in hospital, and these are the ones that we have at the Austin. So you've got the PAPA, which is what you've seen in some of Steph's photos previously, which is used by the Austin COVID intubation team. And it is a battery-powered unit which draws air to the unit, goes through a HEPA filter, and then supplies the clean air to the person, either through a hood or a helmet or even through a mask. And then you've got these ones which are elastomeric respirators, which are basically a non-disposable respirator where you breathe in and the air goes through the filters and you breathe that in. And the bulk of what we use is disposable filtering face pieces, which are what we call N95 or P2 masks. And just a little side note, the N95 P2 masks, these are just different terminologies used for certification of respirators in different countries. So a P2, P1, 2, 3 masks or terminology is the Australian standard. The N95, N99, N100 is the American standard. And you might have also seen people talking about FFP1, 2, and 3, and that's the European standard. And they are all roughly the same, not identical, but roughly the same. All right, so respirator fit testing, what is it? So fit testing is not the same as fit checking or a user seal check. The fit checking is done every time you put on a respirator. And this is where you inhale and exhale and you see the respirator inflate or deflate. And you'll find that these really soft respirators like these BSN medical respirators, they inflate and deflate easily, whereas some of the more rigid respirators like these 3M ones, they're harder to fit check. But anyway, the fit check is done every time the respirator is worn. Whereas the fit test is a formal test to make sure that the respirator is able to form a tight seal on the user's face. And it is mandatory according to Australian standards, but it is not mandatory by law. It is done to make sure that there are no gaps between the user and the respirator where contaminated air could just enter through the gaps. And the studies have shown that fit testing increases the likelihood that the respirator will provide the minimum level of protection for a respirator of that class. Now that last sentence is a really wordy sentence. And what does it actually mean that the respirator will provide the minimum level of protection for a respirator of that class? So here I've got a table of the assigned protection factors according to the American guidelines. And so the assigned protection factor is the level of respiratory protection that a class of respirator is expected to provide in a workplace 95% of the time when the employer implements a continuing effective respiratory protection program. So for a N95 respirator, the kind that we normally use in a hospital, it comes under the air purifying respirator in a half mask. So the assigned protection factor is 10. So what that means is that in ideal, and when you wear an N95, when you've been fit tested, when you've got an effective respiratory program, in 95% of the times, you will reduce the environmental contaminant by a factor of 10. So it will be 10 times cleaner in your N95 compared to what is outside. And you can see here that all air purifying respirators, half mask, including elastomeric respirators, are given the assigned protection factor of 10, whereas a full face piece, so the ones that cover your face, your eyes, and all the way in your whole face, are given a protection factor of 50. And so that is the assigned protection factor. So fit testing, why do we have to do it? This is because we all have different faces. And it might be interesting for you to know that the history of N95 respirators are that they were actually tested and certified based on Air Force personnel facial shape from the 70s. So you can imagine that if you look like Captain America, you have a very good chance, or you have a much better chance of just, getting of fitting an N95, or fitting more different kinds of N95 compared to if you actually look like Thanos. So if you look like Thanos, you need something else. Probably the filtering face pieces, N95s, are not going to work for you. And in fact, one of the biggest studies in the world, which was conducted in South Australia, showed that Asian people had the highest failure rate at 16% compared to people who were considered white in that study, which is at 10%. So how do we do fit testing? There is the qualitative fit testing and there is quantitative fit testing. So qualitative fit testing is a subjective test to see if the user can taste a sweet or a bitter substance that is aerosolized into this clear hood. So in this picture, you can see that there is a person in a clear hood. He's got his head turned to one side, and it's part of the testing where you have to do movements, and it's a standardized protocol, one minute of normal breathing, 1 minute of deep breathing, etc. And during this time, you've got another person who is nebulizing the test substance into the hood. And during this time, if you can taste the substance at all, then the test has failed. And if you have if you don't taste anything throughout the whole test, that means that it has passed. The other alternative is a quantitative test. And a quantitative test uses a machine such as a port count machine, which measures the fit factor. And the fit factor is the ratio of the microscopic particles in the filtering face piece in the respirator versus what is in ambient air. And this number only applies to the testing that is done, not in the workplace, but as a test separate to the workplace. And so we aim for a fit factor of greater than 100 for N95 filtering phase pieces. And this fit factor numbers are not uniform throughout the world. And even the protocol of what is considered a pass is not uniform around the world as well. But in general, just speaking in generally, to pass a fit test for a N95 with a quantitative test, you need to achieve a fit factor of 100, meaning that there is 100 times less dust particles in your filtering phase piece compared to what is in ambient air. So what are the pros and cons of each of them? So the qualitative test is good because it is maybe cheaper in the short term, but more importantly, the respirator remains in use. You can continue to use your respirator clinically after a qualitative fit test. The downsides to it, though, is that it is subjective. Someone can say, yeah, I think I tasted, I'm not sure. And also, not everyone can taste the test substance. And also, if you're doing repeat testing, so if you fail one respirator and you go, oh, I need to test another one, after you've waited the mandatory 15 minutes and you test your second respirator, because you've got a mouthful of that sweet or bitter stuff in your mouth already, despite the fact that you've tried to rinse it out as much as possible, it might still lead to a false failure for your next respirator. And having done the qualitative testing, having done a few days of qualitative testing, the tester gets RSI from constantly squeezing the bulb. And also the tester is covered with the sweet or the bitter substance, which takes more than 24 hours to get rid of. And then the quantitative testing. Quantitative testing is objective. There is a mode on the port count machine which can give you a real-time fit factor. So you can put on the respirator and then you can adjust your respirator, squish it a bit harder, change the straps, make it higher, make it lower. And you can see how this affects the fit factor in real time. And so you can use this mode to educate people, on how to correctly put on their respirator. It is also quicker to perform because there are a few protocols, but the modified OSHA protocol is only 2.5 minutes, whereas the qualitative protocol is 7 minutes. And you can get a printout of which movements have got which fit factor. So you can see that breathing is fine, but talking, your fit factor drops when you talk. So you can see which movements are problematic for you. The downside to it, though, is that it's more expensive initially. You'll either have to rent the machine or you'll have to buy the machine, which is at $20,000. You need a little bit more training to use the machine, but it is not really that super difficult to use the machine. But very importantly, it destroys the respirators because you'll need to put a hole through the respirator to do the test. And so once you've used the respirator for quantitative testing, then you can no longer use it for clinical use. So what have we done in the Austin? So in June this year, after we got our ethics approval and advertising, we started doing fit testing of the COVID airway team and the registrars who might be first responders overnight. And when we applied for the ethics application and just at the beginning of testing, the only filtering phase pieces that were available at the Austin were the BSN Medical N95, which is the orange duckbill. And this is quite similar across most of the hospitals that I work in that this was the only filtering phase piece that was stocked. So this was the respirator that we tested with. So over 1 week, I tested about 65 participants. We did about 300 odd tests. And in this, during this session, everyone passed the fit check according to the DHHS Victorian guidelines, in the sense that you put on this BSN Medical, this orange duckbill, you do the breathe in, breathe out, the respirator flaps in and out. And you go, oh, I don't think I feel a leak. So it does technically pass the DHHS guidelines, but without taking off the respirator, right after they've done that fit check, we do the fit test, and only 22 out of 65 pass the fit test with the port count machine. Now with education or changing the respirator size, a further 16 people pass the fit test. So what this means is that either, I show them on the real-time mode, look, okay, this is what we have to do. You really need to tighten it here. You need to squish it a bit harder. We need to change the positions of the straps maybe. And then if we can get the fit factor to be 100 consistently on the real-time mode, we take off the respirator, we put it on again, and we redo the test. So with education or with just changing the size, going from a small to a medium or a medium to a small, a further 16 people pass. So overall, for this brand of respirator in the testing that we've done, in the cohort that we've had, we could get a pass rate of 58%. And then in August, the department contracted an external company to offer fit testing to the rest of the anesthetic nurses and the rest of the anesthetic department. And importantly, the people who did not pass fit testing with the filtering phase pieces that were on offer were tested with elastomeric respirators. So at the Austin, we used the Sunstrom half-phase elastomeric respirators. And so the ones that didn't pass, the disposables were tested with the elastomerics. But luckily, thanks to the championing from many professional bodies such as the ASA, AMA, in Victoria now, the DHHS has now commenced fit testing statewide. Now, what are the issues with fit testing though? We've been fighting for it, now we've got it, but there are issues with fit testing. One of the big issues is the unreliable supply of respirators. If you get tested on a particular respirator, then that is the respirator that you have to use each and every time. Now, if the hospital has no more supply of that respirator, then you'll have to be retested again. Or if the hospital or if the health purchasing Victoria gets a new supply of a different respirator, people will need to be tested on those new respirators before they can use them in clinical practice again. And for an effective respiratory protection program, you really need to have a few different brands and a few different sizes of filtering phase pieces to fit most of your population. And if you had at least 3 brands, a few different sizes, you're more likely to be able to fit upwards of at least 90% of the population. And the other thing is that filtering phase pieces, even elastomeric respirators, they don't fit users with a lot of facial hair. There are some people who, for religious reasons or for personal reasons, do not want to get rid of their facial hair, or they've got facial abnormalities, they've got large scars, they've got dental work, which makes their face shape not your typical Captain America face. And these people do not fit filtering phase pieces or elastomeric respirators. And in this case, they really need to be looking at a non-fit tested device, such as what we've been using, what the airway team has been using, which is a loose fitting or hooded type of respirator. And it's important to note that fit testing does not guarantee that the user will have the expected level of protection. It means that you have the potential to have that level of protection, but it is not a guarantee. This is especially true if you are using it for a prolonged period of time, or if you're using it for very strenuous activities, because the studies don't actually address that. And it's also important to remember that fit testing and PPE in general is the weakest component in the hierarchy of control. So the hierarchy control is a paradigm for managing risk in the workplace, and things like eliminating the risk is much more effective than PPE, because PPE depends on each and every one of us wearing the correct PPE, doing the correct thing each and every time. So if you can eliminate it, it is much more effective than wearing PPE. But unfortunately, that is what we have. That is what we need, because, you know, we can't eliminate, substitute in all of the COVID patients. So in summary, fit testing is important to make sure that the filtering face piece or the respirator is able to fit the user. But not just that, it's not just about, yep, I passed, let's go, let's move on. Just as importantly, fit testing is an opportunity to educate the user on a one-on-one basis on how to correctly use their respirator. And it includes looking at the respirator when you first take it out of the box. Does it look right? Are the straps correct? Have you got staples missing? And how to don the respirator correctly, how to doff the respirator without contaminating yourself, and how it actually feels on your face when this respirator is working correctly. And so that's it. That's all I have to say in terms of fit testing. Want to say that, you know, like Cinderella and finding a shoe that fits, fit testing is about like trying out a shoe in a shop before you buy it. And it means that, you know, at least you have the potential to this respirator that you have in your hand that you're wearing has the potential to at least give you the recommended, the protection that it's supposed to. Thank you very much. Back to you, Ainsley.
Thanks, Caitlin. Just a few questions. Was there anyone that you weren't able to adequately fit an N95 to, and what did you do in that situation?
So in our original little pilot, like in our research study, yeah, there were lots of people that didn't fit, that didn't pass a fit test. Some people resorted to, oh, I'm just going to put a tape, and a lot of people could pass with a tape, but that's not recommended practice, because when you doff, when you've got a tape on, I've seen people that flick the respirator into their mouth, and so that's really not recommended practice. But at the Austin, we're very lucky. From very, very early on, Daniel had bought a pile of elastomeric respirators, and these elastomeric respirators very, very, very rarely fail a fit test.
Another question, what is a long period of time to wear an N95? What is too long potentially?
It is how long is a piece of string? The studies don't, you know, tell you how long it is. They don't have studies per se that I found anyway that looked at how long is too long. But so really the answer is I don't know how long is too long. But personally, I myself find that when I wear the orange duckbills, and this is the one that I fit test and pass on the small, is that after a period of time, I can feel that it is loose now. It no longer feels tight, because I know that when I pass the fit test, because I have a porta count machine. When I rent the porta count machine, I test myself. You know, I can test myself every day. So I know that if I can speak normally, it doesn't fit. When I speak with a real nasal tone, that's when I pass a fit test. So when I can hear myself normally, I know that the fit has actually changed. And so no, I don't know the answer to that. It is how long is a piece of string?
Gotcha. Yeah. Thank you. Yeah, cheers. Look, I've got a question for Jane, if you're still there. I think I saw you just popping into the car, Jane. Being a woman, I'm sure you can multitask beautifully. How sick did the staff in ICU get? And did you find that those who did get sick had a higher viral load?
Thank you. You're talking staff getting unwell. Is that what you're asking about?
Yes, the question was just relating specifically to staff, if any did get sick from COVID.
So we had some people who were at home. We had one individual who was from an outside hospital who ended up in an intensive care unit but required oxygen and nothing further. So that was our experience. I'm not sure if it meant other people presented to other hospitals, but our experience was the majority of our patients, the majority of our staff, the majority of our staff who were unwell in the hospital were mostly at home.
Okay, great. Thank you. I have a question for Steph Chen. How would you do things differently? And did you increase the infrastructure in preparation for future ramp-ups of COVID? Hopefully that won't happen.
In terms of what we do differently, I'm not sure there's anything we'd really change. I have to say that I think everyone, both in the Department of Anaesthetics and everywhere else, was very, very cooperative and very enthusiastic. And I think the biggest challenge that we had was continually changing guidelines. And that was one of the big frustrations, that a sim one day would rapidly be obsolete by another day. But I don't think there's anything that we could have done to really change that. But in terms of the way that we rolled out the sims, we were really blessed that the department had prioritized getting people through training and PPE, that people would be rostered, and trainers, either simulation or PPE, would be rostered to have actual sessions purely just to educate. And I think that really made a difference in getting people through in a timely fashion. So I'm not sure that we will really change anything. In terms of ramping up infrastructure, I guess we have. I mean, through this experience, what has sort of developed from that is that we've really increased the faculty in the sim sort of department. That's going to really allow us to be able to, if it happened again, touch wood, rapidly be able to deploy people and have a much easier way of reaching more participants in a shorter period of time with more faculty. And I think also, as we've done so many sims now, the learning experience is always so exponential that now having a short sort of time frame to put a sim together is almost normal for us. So our response in a future sort of pandemic-like thing hopefully would be much smoother. I don't think there's any sort of hard infrastructure that we've changed. I think it was just things that we were able to be really flexible about. And now that we have the knowledge of how to do things, we're going to really be able to respond much quicker in the future.
Okay, and just while I've got you, I've got a question from Susie Cook.
Mm-hmm.
With regard to SIMS, was there much difficulty getting buy-in from operating room management? For example, facilitating locations, staff availability to participate in education, in opposition to production pressures and staff shortages?
Once again, I think we were really lucky. So a lot of our SIMs happened at that time where we'd already decreased the amount of operating we were doing electively. And so there were locations that were already no longer being used. So it's not that we had to kick anyone out of theatre, that there were empty theatres that we could access. And I think once again, everyone either in the Department of Anaesthetics or in nursing and the operating suite were very, very supportive, because I think there was a lot of that fear of healthcare workers getting infected. And so they would prioritise getting people out and rostering people in each different craft group, PSAs, techs, everyone would get rostered to come to simulation, and everyone was really supportive of that. So we never got any fight back. Some people weren't particularly interested, but they would have to come to at least one mandatory session and they would still do that. Like we never really got anyone that said, no, I refuse to come.
Great, thank you. This one perhaps might be best directed to Emily. It's from Stephanie Armstrong. Could you please expand on the management of and advice you gave, sorry, hang on, it's just gone. And the advice you gave regarding patients with COVID who are pregnant. Emily, I'm not sure if you're able to answer that one for us, please.
It's probably a little bit beyond sort of the area of expertise I have coming from an anaesthetic background, but I can certainly sort of talk to some general principles. I think the unofficial advice that was given was that pregnant women, where possible, should be moved out of high-risk environments. Officially, though, I don't think there was any guidance coming from any of the major colleges or workplaces mandating that to happen. So early in the pandemic, certainly at a British level, the Royal College of ONG over there had initially sort of given that sort of 28-week threshold as sort of like a good time to be moving yourself out of a workplace which might be considered to be high risk, and sort of socially distancing as much as possible, given that the most significant risks will be risks of COVID in late pregnancy. And I think anecdotally we probably were aware of that happening in our workplaces. So a lot of anaesthetists, for example, were doing non-clinical roles if they were pregnant, or nursing staff were moving or not putting their hands up to do sort of COVID ward work. But I suppose it just really was negotiated on an individual level between the woman knowing her specific health requirements and risk factors, her workplace, and potentially seeking advice from her obstetrician or healthcare provider about what they'd suggest. But I'm not sure if there's anyone with an obstetric or a occupational health or infection control sort of background on the line who might like to give a little bit further input to that question.
Thanks, Emily. I'm not sure anyone's popping their hand up at the moment, so we might move on. Thank you. Perhaps time for one last question. Shiva, I hope this is okay with you. So the question is, all right, not everyone fits the N95. What happens if you pass the initial fit check, Caitlin, but you fail with the machine? Do we know what risk there is for potentially catching COVID in this sort of patient group? And did you see this occur with your fit testing and fit checking?
So to answer that, that's a difficult question because in truth, we don't know what the risk is of you catching COVID, even if you weren't wearing an N95 respirator. There is a case report that came out of Singapore of a patient who was intubated, had non-invasive ventilation, was intubated, and had a lot of aerosol generating procedures done. This was prior to people knowing that he was COVID positive. And a total of a large number of healthcare workers were exposed, but none of them actually contracted COVID, despite the fact that nobody was wearing an N95 or N95 equivalent. They were all wearing surgical masks and barrier protection and stuff like that, and droplet precautions, but not N95 type protection. So what is the risk? Who knows? Because it depends on what you're doing. It depends on the patient's viral load. It depends on your host immunity. It depends on what gets given to you, what's in the air, because even a poorly fitting N95 does provide some degree of protection. It's just that it will not meet that minimum of at least 10 times if it is poorly fitted. I have seen during fit testing some people who go like, oh yep, great, this is how I normally wear it, and you do the fit test and the fit factor, so this is the best case scenario, is less than 10. And so you can expect that in a real world scenario, it is going to be definitely less than 10. That scenario is different to someone who, say, maybe doesn't pass, but they get a 90, doesn't pass fit testing, but that there is some degree of protection from it, and so that it's a very, very gray area.
Great, thanks, Caitlin. I've just got one more question for you actually while you're there. This is from M. Horn. Caitlin, you have a lot of experience with respiratory protection devices and fit testing. What would you say about the recommendations by the DHHS to put tape on the bridge of the nose, for example, a thin hydrocolloid dressing, Duoderm or Tegaderm, or a foam dressing such as Mepilex, placed on facial pressure areas caused by PPE? Surely this interrupts the seal potentially, and checking after dressing application by a fit check is inadequate.
So Michelle, this is from Michelle, whom I know. Michelle, I've seen this DHHS recommendation. I think that it was raised with some of the occupational hygienists as well at the ASA webinars. And as you know, things like putting in extra things, tape, under, above, wherever, anytime you're adding a variable to it, it's not ideal. Because the thing is, let's say if you've never been fit tested on it, yes, it could potentially impact the seal. It could potentially, maybe it doesn't. Maybe it does. I don't know. Or let's say you go like, no, I definitely want to wear this dressing. So you do a fit test with this dressing and you pass. Great. But the thing is, the next time you put it on, is it exactly the same as how you've put it on when you were tested? And this is exactly the same thing with people with beard or with a stubble, because technically especially with elastomeric respirators, could potentially get a pass on it because they're a little bit more forgiving, the elastomeric respirators. But the problem is, if you have a stubble and you pass on it, how do we know that tomorrow when you wear the same respirator that the stubble is not a little bit longer, or your facial hair is lying a different way to when you pass fit testing? So it introduces another variable. In the ideal world, you would not add anything other than you and the respirator and maybe your usual eye protection. That would be ideal. But I know that the DHHS has recommended what they've recommended because people were getting bruises and terrible pressure sores from it. So they are not ideal, but I'm hoping to do another study to look at the different types of respirators, whether some are more comfortable than others, and whether some are more likely to pass fit testing than others as well.
Okay, great, thank you. Got a question for Vanessa Andean. What do you think the aftermath of COVID or post-COVID depression will be like? Vanessa, I might just get you to unmute yourself, actually.
Sorry about that. I think that's a really interesting question. And like so many things in this pandemic, technical things like when can we anaesthetise someone who's had COVID? We don't know the answer to that. Someone who's treated COVID patients, how long will they have wellbeing issues for? I think all of these things are unstudied, and once we've had a chance to look at them with a bit more longitude, we will have some answers, but I think they're also very, very individual. So wellbeing is always a summary of what the person brings to the situation as well as what the situation was. So I think we just need to watch this space.
Okay, great, thank you. Shiva, I think it's over to you.
Okay, no, thank you very much, everybody, for a great work there, great presentations. And I feel a bit honored that you guys have been so fantastic for a presentation. Also quite interesting, the questions. If there's any questions that anybody has got, we will forward it to the speakers. I will send a copy of their recording in my thank you letter to everybody, including all those who didn't attend but registered. And let me know if there's anything else we can do. There will be a Q&A. There will be a questionnaire survey monkey to fill as well, which would be very much helpful. And I hope that we will not go through another wave again, but I'm sure that we have gained a lot of information, a lot of insight, knowledge, and skills to cope with anything in future. Thank you very much, everybody, and I'll see you guys soon. Thanks. And good luck and have a nice Sunday evening.